Bwrdd Dda, good morning everybody. Welcome to our public board meeting, particularly to the members of public who are joining us through our live stream. As we all know, we're in the most difficult time of this pandemic, which is impacting on all our services, our staff and our public. And tragically, many have lost their loved ones. On behalf of the board, I would like to give a heartfelt thanks to the public who continue to make such personal sacrifices to keep the pandemic at bay in West Wales, and to all our staff who have reached into their innermost strength for such a long time for care for our patients and to care for each other. We will hear at today's board meeting how the mass vaccination programme, the biggest in the history of the NHS, is being rolled out across Hywel Dda, and how everyone in the voluntary sector, our teams, our partners, the RAF, universities, are all working together to protect everybody and to save lives. I'm going to go straight into the agenda. There are no apologies today. Are there any declarations of interest? No? Okay, thank you. If I go into the meeting, the minutes of the meeting held on the 26th of November 2020, are there any issues in relation to matters of accuracy? Thank you. So is everybody happy to approve them as a true record? Many thanks. Then go into the matters arising. Are there any issues in the matters of arising? I have one in relation to PM 20186, clarification as to where this will be the formal update on the communication with patients, which was provided to the executive team on the 20th of January 2021, will be scrutinised in our committee structure.
Yes, thank you, Chair. If I can respond to that, we will be providing an update through Quality Committee in terms of the progress that we're making as a matter of routine, as well as making sure that the exec team are briefed, and I hope to be able to bring a future paper to board once we've made some further progress.
Thank you, Mandy. So will the next report go to the next Quality Committee?
It won't be the February meeting because we've already got the agenda for that, but it will be the meeting after that. So I anticipate taking something in April.
Thanks, Mandy. Has anybody got any questions on that? No? Okay, thank you. Then move on to the next item on the agenda, which is my report, which you all have before you. I'm really pleased to report the opening of Llandovery Hospital, Community Hospital, and Cardigan Minor Injuries Unit, and I'd like to thank the local communities for their patience and understanding and support, and also the support of all the local GPs in both the areas. So we're really pleased that that's happened. As you can see from my report, we also set out those members of our staff who have been recognised nationally and locally for their dedication and expertise. I'd like to draw particular attention to Bwrdd, Head of Long-Term Care, who received the British Empire Medal in the Queen's New Year's Honours List for the rollout of COVID-19 testing in our care homes in West Wales. And also I'd like to draw attention to one of our young people, Will, who is, he also got an award. He's one of the physiotherapy technicians at Glangwili. And it was great to hear him live on the radio. He's also one of our apprentices. And I'm also pleased to confirm that Mrs. Hazel Lloyd-Lubran has been appointed the chair of the Stakeholder Reference Group by the Minister for Health and Social Care. I understand, Mike, you'd like to ask questions on the chair's report?
Yes, if you finish the report, Chair, please.
Oh.
Just on the Penally camp update, I'm sure the members will be disappointed with the position when you updated this particular report. I just wonder whether there's been any update since the writing of the report, please, or the writing of the update.
There is a meeting after board today, and Jill is going to be attending on behalf of Steve. We haven't received a response to the detailed concerns that we raised and asking for assurance in relation to the camp, as I stated in my report. There has been some information in the public domain in relation to people who are staying at the camp will be moved out slowly, but I haven't had any official confirmation of that, solely what's in the newspaper. But I'm happy to ask Jill if she could update members post her meeting this afternoon with the Home Office. Jill, are you happy to do that?
I think they're stuck on mute.
I think you're on mute in the carer room.
That's it. So I think live now, yeah.
You're live.
Thank you. Can you hear us now?
Yeah.
You can hear us?
Yes.
Thank you. Yes, thank you. Sorry about that. We've had some difficulty with technology here. Yes, I'm very happy to report after today. I think there's a particular focus at today's meeting on the issues around COVID as well. There were some issues raised by Public Health Wales, and we know that a representative of the Home Office will be present to discuss that. And also the rumours that were in the press that there was going to be a more immediate dispersal of residents from the camp. There was a response, I think, at the end of last week to say that that was not the case. They were really continuing at this point with their gradual dispersal in and out of residents. And I think we've got about 117 residents there at present. So I will discuss those issues this afternoon. We're also talking in Cusiac next week around some of the ongoing issues around the care and support and the services that we're providing, and I'll be very happy to report to board members after today's meeting and also when we meet in Cusiac.
Many thanks, Jill. Simon, you'd like to come in as well?
Yes, thanks, Chair. I just wanted to, it's on page 2 of your report. When you think that the BAME advisory group was only established in the summer, I think it's the whole field of work has made astonishing progress, and I just wanted to welcome the announcement that's been made that we've got funding to fund a community outreach team working with the BAME community. So it's got real focus and it's got real pace, and I just think that's something that we should all welcome. Thank you.
Thanks, Simon. I totally agree with your comments, and I'm really grateful for those members of staff throughout Hywel Dda from a BAME background who've really embraced this and are leading it and taking it forward. And as you know, at our board seminar, we had 2 really good presentations from the co-vice chairs, and we did stand down the meeting this month because of all the pressures, but we start again shortly. But things have been going on in the background, and we've managed to enable Augusta, one of our members, 1 day a week to take forward the task group on racism and bullying, which is really, really good. So I'll keep reporting back on that to the board. But thank you. Any other questions on my report?
Dennis has a comment, Chair.
Dennis?
Children and young people.
Yes,
hello, Bwrdd. Yes, please. I'd just like to recognise the involvement of 2 young people in particular to our board seminar in December. One of them is an apprentice and the other one is a service user with CAMS, and we really welcome their involvement in moving the agenda forward.
Absolutely. Thanks, Judith, and it's so important that we hear all the voices, particularly those that we don't hear as much from, or we don't give them much attention to as a board. So thank you. The board's happy to accept the recommendation in my report. Many thanks. So we go on to the next item of the agenda, 2.4, which is maintaining good governance, and that's Jo.
Yes, thank you, Chair. So as we're still in the middle of the pandemic, this is the update that we present to every public board meeting, so we can demonstrate the amendments we've had to make standing orders and SFIs during this time. There is also an update on where we are with our risk management approach, and an update on our auditors, their programmes, and where we are in ensuring we continue to implement some of those recommendations where we can. There is a recommendation for 2 approvals within the paper, Chair. One is to approve another bronze group for the vaccine delivery, which will report into our tactical group within the command structure, and really for any questions, Chair.
Thanks, Jo. John.
Thank you, Chair. So I welcome the structure that we've got in terms of command and control, which is quite robust. My question essentially is, are we assured that the decisions and what informs the activities within these groups are communicated appropriately to our established board structured committees, so that we as IMs and colleagues are able to undertake appropriate scrutiny?
Thanks, John.
Thank you, Chair. Yes, John, absolutely, they are. So any planning instruction which Gold Command approve is brought to every board meeting for ratification, so they're in full sight of the public domain. Any areas that come out of tactical, for example, the vaccine plan, or any other key areas that we need to look at, all feature in the assurance committees, either quality and safety, and there'll be some with a request later on to come through to your committee shortly, John, or to the finance committee. So yes, they are in full sight of all of our committees, but the main thing to note is that any planning instructions from Gold are ratified by the board in public session.
Thank you, Chair.
Thank you, Chair.
Jill.
Yes, thank you. I just wanted to really commend that and also just to assure board members how robust actually the system is. And we've got such a well established now arrangement through our bronze and silver groups, and if necessary up to gold, and also to the board committees. I do want to say how much it has brought the organisation together in terms of all of our operational services right across the whole system, partaking in those decisions and discussions. And one example that we had actually, which did go to PPAC at the just before Christmas, was the decision around the need to stand down some of our services within our acute level to release staff to work in those most essential areas. And again, we took that through our silver group, and that went into our PPAC committee for quite a full discussion just before Christmas. So it really does evidence, in fact, that sort of line of sight for the board in terms of what's happening operationally and the direct relationship with the board around any of those decisions and oversight as necessary. So, but I do want to assure the board of the robustness and the joined up way in which those conversations are taking place.
Thank you, Jill. Going to bring in Judith.
Yeah. Oh, good morning. Sorry, there's a little lag while you switch your camera on. Yeah, I suppose just wanted to add to the assurance situation in respect to the two committees I chair, which are Health and Safety and the Mental Health Legislation Assurance Committee, that there are robust arrangements in place for the lead officers to communicate with me, and where necessary, chairs' actions being taken, which was then reported through to the board. And it is our intention to hold a Health and Safety Committee meeting in February and have the Mental Health Legislation Assurance Committee meeting in March. Although it might be a reduced agenda for both of those, we will continue to keep the focus on the issues that come to that committee. Thanks.
Thank you, Judith. And thanks everybody for John, thank you for the question, and also Joe for the paper, and Jill and Judith for providing assurance. And I'd really like to thank Joe, because I think throughout this pandemic, the governance has been exemplary. So thank you. Are the board happy to approve the recommendation, which includes approval of the temporary changes to the programme of work and the meeting cycles for the committees of the board, and the changes to the command and control structure, including the establishment of a bronze vaccine delivery group? Many thanks. If I could then go on, please, to 2.5, the report of the Chief Executive.
Yeah, thank you, Chair. I won't go through the details of the report. I think it's relatively short and to the point. There was just one minor amendment to it, which is at the end of the assessment section around the Director of Strategic Development and Operational Planning appointment, to say that we changed the choreography slightly so that the stakeholder events happened on Monday with feedback to the panel on Tuesday. We're taking 2 forward to interview tomorrow. So we'll be able to update board members following that process tomorrow.
Thank you, Steve. Are there any questions? Okay, thank you. The board happy to accept the recommendation? Yep, thank you very much. Next is the report of the Audit and Risk Assurance Committee. I can go over to Paul.
Hello, thank you, Chair. Good morning, everybody.
Morning.
Yes, the report sets out the work from the last meeting of the Audit and Risk Assurance Committee from the 15th of December. Just to take you through a few items from the report, you'll see that we have carried out a review of the standing orders, and there's some revised standing orders with the pack for approval today. If anybody's suffering from insomnia, I'd recommend an excellent read. First, on a more serious note, to draw attention to the Audit Wales annual report. That is an excellent report. It really does reflect, as we've already mentioned, the excellent work which the whole governance team and the other members of the executive team undertake in making sure that the health board stays on track. And I commend the report to the board. There was a report which we considered again by Audit Wales in relation to the refurbishment of Glangwili, and there's some for the health board, particularly as we go into the development, hopefully, of the new hospital. I know we've got some discussion on that coming up, and it would be good to have some assurance that the recommendations from that report have informed part of the discussion around the arrangements for the development of the new hospital. Draw attention to the backlog maintenance internal audit report. As you see, the report itself had a reasonable assurance report, which really just reflect the way in which the health board is managing the backlog, but it doesn't necessarily give too much assurance in the sense of the amount of and value of the backlog maintenance work which is required. And I sort of use the analogy of we were a bit like a boy sticking out his finger in the dike in order to stop the water coming through, and there's a number of holes that we have to continue to plug really to make sure that our estate remains fit for purpose, and the importance therefore of the business case which the health board has presented to Welsh Government, getting approval from Welsh Government. So there's some issues in there for the board, and finally the KPMG review of the transformation fund. It refers in there to some discussions taking place outside the meeting, and I've got a meeting scheduled with the board secretary for Monday of next week to discuss that. So a few things at the end of the report for which I've sort of highlighted as I've gone through the report, but happy to take any comments or questions.
Thank you, Paul. I know Michael has indicated that he'd like to come in on the Wales Audit Office annual report, and I'd also like to welcome Jeremy Saunders, Audit Wales, who's going to present that item at 2.62. But if I bring in Michael first.
Yes, thank you, Chair. Just on the WAL report, I was just reflecting on if you compare it with previous reports over the last few years, it definitely demonstrates a growing maturity, I think, with the leadership and the management of the health board generally. And I think it reflects, and I'd be interested to see Jeremy's view on this, I think it reflects a growing confidence of external stakeholders in the executive team's ability to be able to manage an organisation through a really difficult public health crisis.
Thank you, Michael. If I may bring in Jeremy first, I'm going to go straight to the annual report and then go back to the other issues that have been raised by the audit committee. So welcome, Jeremy, and over to you.
Thank you, Chair. Do you want me to quickly introduce the report or just answer the question?
You choose.
Okay, well, I'll take
Over
this opportunity rather than follow the agreement of the standing orders, which the Chair of Audit Committee, Eric, has already said is a pretty dry item. I'll present the report and answer the question at the same time. Thanks, Chair. I agree. This does demonstrate the health board has shown improvement over since I've been the auditor at the health board. There's been a gradual improvement in terms of governance arrangements and the way you manage excuse me, your affairs, and particularly last year where we had the pandemic to deal with as well. You demonstrated the continued improvement even throughout that period. So at that point, I'd invite any other questions on the annual audit report.
Thank you, Jeremy. Are there any questions from members on the annual report?
Just say one thing. As Paul's already alluded, we have been through this in audit committee, so I just didn't want anybody to think we haven't been through the report in detail, and it's been shared with board members as well prior to the board. But also just, I know from myself and Hugh in particular, Jeremy is retiring from Audit Wales, so just if it's acceptable, Chair, on behalf of the board, to thank Jeremy for all his work, because I know Hugh and I have valued Jeremy's input over the past few years.
Thanks, Joe. And I think you might wish to come in.
Many thanks. Yes, just to echo that. Thank.
That's very kind of you. I'm flattered.
We wish you a wonderful retirement and thank you for your report before you go. That was, yeah, it was it reflected the reality, I would say, and also it's a welcome boost in these difficult times. And an assurance to the board, so thank you. So if we pick up the other, well, we'll go straight to the standing orders, where the chair of audit committee was speaking from experience about it helping insomnia. Are the board happy to accept the amendments? Yeah. Many thanks. And then if we could pick up the other two issues, one is the KPMG and the reporting arrangements. So if we could have an update at next board, that would be really helpful about the governance arrangements. Thank you. And then the other one was, I totally agree, Paul. I'm sure the whole board agrees about learning the lessons from Glangwili, and we look forward to discussing that further on in the board meeting today. But there was also the issue about our backlog maintenance and the need for a strategic approach at scale and at pace. And I wonder which executive would like to respond to how we're going to do that or where we're going to do it.
I think Andrew and Hugh were going to come in.
Okay, Andrew.
Thank you, Chair. Good morning. So I'm having a few technical issues this morning. So my papers are kind of not downloaded now. I haven't downloaded them during the week. So I'm a little bit blind. But in terms of this issue, we did take through committee just before Christmas programme business case for Welsh Government to support the major infrastructure schemes, which includes the work that we need to do around addressing our major infrastructure backlog and maintenance backlog. That case is currently subject to scrutiny by Welsh Government, and we've had their initial set of comments back and are just working through those. As we're doing that, the team are also then developing the plan around how we would, assuming we get support for that, how we would implement that and take that forward at the required pace and scale that the board and we would all expect to see.
And will that be scrutinised, Andrew?
That would be scrutinised through PPAC, I think.
Many thanks.
Just looking at you to make sure I've got that right.
Yeah,
yes,
correct.
Absolutely.
Right answer. Hugh.
Yes, Chair, thank you. And just to add to that, of course, we've got the programme business case update on the agenda shortly, which while doesn't directly address the backlog maintenance, will significantly change the estate of the health board, and over the medium term, along with that, and repurposing the sites, then that will also make a significant contribution to, in the long term, addressing the backlog maintenance issue in a sustainable way.
Thank you. Well, thank you both. Any questions?
Chair, Paul Newman would like to come back in.
Yes, Chair. Clearly, we obviously hope and indeed expect that the project business case that we put into Welsh Government, it does meet with approval. But if it doesn't meet with approval, then clearly this issue is going to need to come back and be considered, because we'll need to find a way in which we can realistically solve the problem, because the current situation is obviously not sustainable.
Thanks, Paul. And you have lots of nodding heads there. So thank you. We will ensure that is the case. Are there any other questions? Okay, thank you. We're going to now go on to delivering our strategy, which is the programme business case implementation. And I'm
Hugh, just to say before Hugh comes in, it's just great to see us here today.
Yeah.
Everything else going on, but I'll hand over to Hugh.
Yeah, I totally agree. Hugh.
Cadeirydd, diolch. This is an exciting opportunity to have an update on the programme business case coming. It's a once in a generation opportunity for us in West Wales, and I'm really pleased to have been able to play a part in pulling this together to bring it today, with thanks to a significant team of people who've been working on this, led by Paul Williams, who is on an interim basis reporting to me. Just in terms of an update for the board, and I think the paper fairly speaks for itself, but work on the programme business case is progressing well. We're aiming to get a programme business case to board in Q1 of 21-22, which is slightly behind where I had anticipated at the outset of last financial year that we'd been, but clearly we've had a number of challenges to deal with over the last year. The plan is to have a programme business case in June, with then the full business case all going well by March 2024, which feels like a long time away, but given the work that needs to be done in this space, actually will go very quickly. It's worth just talking about the process that we've followed to get to here. There've been a number of, I think we're on the third, we've had the third programme group meeting with the Chief Executive as the senior responsible officer. And we've taken those that time in those meetings to be really clear on what our vision is for the programme business case for the new build. And it's important to recognise that while this is about developing a hospital, a site, a facility, this is very much in the context of a transformed health and care system as a whole. The presentation itself highlights the key issues. If I just start off with the vision, and we worked on this with a number of stakeholders in bringing it together, including actually the Future Generations Commissioner, who attended the last meeting and gave us some insights into how we ought to be thinking about the impact of this on our future generations. It has been challenging to a certain extent, and quite understandably challenging to get clinical engagement. Nonetheless, I think the team have worked really well across our clinical teams, and I am grateful for clinical teams across the organisation who've been able to give some time to provide their insights into our work. While you'd expect the vision to include issues like digital and like carbon neutrality, and clearly they're very critical to us in thinking about the new site, and it's important that this feels uniquely West Walian. I think there's something very important that this building, this hospital, will be bedded within the local community, knitted by our local communities, the phrase that came, and is seen as an asset for the community as a whole, not something that is purely almost an NHS asset. This needs to be something that we all own as residents of our communities. And to that extent, we've really explored the role that the foundational economy has in thinking about this, and how it's important to ensure that the community is involved, not just in the planning, the development, the build, but also the ongoing running of that. And I know the discussions that we're having with contractors now and with some of our advisors are, how do we make sure that in our future contracting arrangements, issues like apprenticeships and opportunities for local people to get involved in this are very much at the forefront of our thinking. Clearly there are risks in the work that we're doing, not least because we are undertaking a lot of this work in the middle of the pandemic, and that does have an impact on the ability of clinical teams to engage as much as we would like, but we're mitigating that risk as far as possible, but it remains a risk for us. What I do need to bring to the board's attention is the governance structure, which is outlined on on slide 4 or page 145 of the bundle for today. And the important thing to highlight there is that the connection to board will be through PPAC. I do think that that's probably an interim governance approach at this stage as we develop the programme business case. As we go into the next phase, I think we need to revisit that governance structure just to make sure it's fit for purpose. And of course, hopefully by then we'll be out of the pandemic and able to do something slightly differently. So that will be a discussion that we will need to have in due course. With that, Chair, I'm happy to open for questions.
Thank you, Hugh. If I could bring in Maynard first, then Mike, then Owen, and then Jude.
Thank you, Chair. Hugh, on page 2 of the SBAR, it lists a number of external appointments that have been made. I was just wondering what processes were undertaken to choose these external appointments as our advisors.
Yeah, thank you. And the process followed has been managed very closely with specialist property services in shared services, and we followed the usual procurement processes that you would expect us to follow there, with a tender process involved, with a balance of financial and quality being the key metrics used to determine the winning bidder, as it were.
Thank you, Hugh.
Mike.
Thank you, Chair. Hugh, thank you. I share your excitement of this paper. I think it's really great to see the strategy moving forward. So, we've been waiting for this programme business case and the strategy update with bated breath. So thank you for that. Loads of questions we could ask, but one specifically, I'm just mindful that we always said when developing our strategy that we can't do this alone. We've always acknowledged that. And one aspect of that is potential upgrades to strategic road networks and indeed public transport links. I just want some assurance, please, that we are fully engaged with our stakeholders and especially Welsh Government, because some of those upgrades and some of those investments won't happen overnight, will they? Some of those are equally long term in line with our strategy. So just some assurance, please, that we are fully engaged with our stakeholders on those aspects.
Yes, clearly very early stages in that, and that issue becomes much more pertinent when we get into the next phase of the business case process, and indeed the site selection phase, which isn't part of this initial programme business case. So as we get into that phase, then it will become absolutely critical that we got the right engagement with the right authorities. We're having early discussions at the moment, and nothing beyond that. But yes, it's very much at the forefront of our mind.
Thank you, Owen.
Thank you, Chair. Question, Hugh. You referred to the diagram on page 4 in relation to the reporting structure, and I just wanted to check the wider connections and assurance that's in the box there, as to whether or not that's intended to include our advisory groups like the Stakeholder Reference Group, the BAME group that was mentioned earlier, and other advisory groups to the board.
Thank you, Owen, and absolutely. All we've given there is just some examples of the connections we need to make. I'll make sure that the ones that you've just mentioned there are absolutely part of the connections and the wider assurances that we will be seeking and using. But there'll be a process of engagement which will be far and wide, especially as we get into the site selection process, which does need further work. Thank you.
Excellent, thank you.
Judith.
Thank you. Thank you, Hugh. On page 1 of the SBAR paper, and you did refer to it about the site, and I understand why this isn't in it now, but as you know, this was of great interest when we were conducting the engagement events. And whilst I'm not expecting you to tell us where, I just wonder whether you could give an indication of the timescales as to when that might be confirmed? And my second question, if I may, I went to an event yesterday with where Welsh Government presented on the new socioeconomic duty, which is due to come into force as required legislation fairly soon. And I just wondered whether there had been early discussions about where that duty fitted with this plan, because it does apply to all strategic decisions. Thanks.
Thank you, Judith. And just in terms of the site, clearly there is a process that we need to go through to determine the appropriate site. We've not begun that process as yet, and it would be premature to do that in advance of delivering against a programme business case that at least outlines the strategic context within which we'll be operating. But as we go into the new financial year, absolutely site selection becomes important. We've already engaged with advisors who can support us with that, so that's all. We're already on. They're already on the books. So we just need to get to a position where we can open that up for their thinking and their development, and indeed the engagement that we will need to go through as part of that site selection. Anticipating that could take us about 6 months. So if we look at that from the date of kind of May, June time when we'll have the programme business case, that takes us up to the autumn, potentially December.
Okay, thank you. On the socioeconomic duty?
On the socioeconomic duty, thank you, Judith. Yes, we are cognizant of that. It's that one is in fairly early days in terms of development, so we need to do some more work on how that will impact on our duties. But in terms of our broader foundational economy responsibility here, I think we're taking that very seriously. We had a discussion with Sophie Howe, the Future Generations Commissioner, and I think there's some really useful learning in that in terms of the social value that we need to be thinking about as part of this development, and that will form a part of the programme business case and will be further outlined in that document.
Thank you.
Thank you, Hugh. If I could bring in Phil and then Donna and then Paul.
Thank you, Chair. And I suppose the point I was going to make is that the issues that drove our strategy all the way through up to when we agreed our health and care strategy in November 2018 still exist, and if anything over the years will become more challenging, and therefore I really welcome this paper and the sense of pace and urgency about the programme itself. And I think as a board we need to remember that whilst of course there's all the focus on COVID at the moment, in the background there are those intrinsic issues that drove our strategy. And I think our clinicians know that, our public know that, and whilst there's an acceptance, I think that through COVID, of course, we've had to reprioritise our actions. I think there will be a real expectation of progress, and I think we will be able to engage with our clinicians, partners and public on this, and I do think it's something that will allow us to bring hope, optimism and positivity as we do emerge from the pandemic. But I think as a board, we really welcome the sense of pace. I think we're going to have to really push ourselves on the timelines in almost every aspect. I know it's not all about the hospital. We are making huge strides in community primary care, in the digital developments, but we need to do that in our hospital system as well. Thank you.
Thank you, Phil. Donna. Sorry, Hugh.
Jim, may I just respond, because there's something, and thanks, Phil. That's a very pertinent point to make. I think clearly it's been a challenge to make sure that this can be managed, if you like, behind the scenes largely, while the work going on in responding to the pandemic has been pursued at pace. I guess the assurance I can give to the board is that we have been quite opportune with our use of time when we've been able to get clinical engagement, and I really want to re-emphasize that thanks for those teams who've been able to give some time, and we've made the most of the snippets of time that we have had when clinicians have had the opportunity to divert attention just marginally away from the here and now to think about the longer term. And I think actually those who have engaged have really welcomed the opportunity. They've not seen it as a distraction. They've welcomed the opportunity to think about something different for a very short space of time.
Thanks, Hugh. That's really enlightening. If I could go over to Donna, please, and then Paul.
Okay. Thank you, Chair. I'm asking a question on behalf of our Chairman, Mr. Mansell Bennett, who's unable to come through this morning for technical reasons. Obviously, part of the plan for the new hospital is looking at involving the public, particularly in terms of the design, etc. And Mansell was keen to ask how that is going to happen, especially in line with sort of the health building notes that create some constraints on what can be done.
Great, thank you. Absolutely, and that's a key part of the vision really now, that we need to make sure that we engage actively with the public when we get into the design of the building in particular. Now clearly that's not necessarily part of the programme business case stage in itself, but as we get into earnest in terms of planning what this looks like, what it feels like, very much need to make sure that we're engaging with the public. Now the one thing that the pandemic has shown us is that we can be far more creative about the way in which we work, and the opportunities for us to engage with people face to face, but also like this over Teams, and using some of those opportunities quite creatively will, I hope, give us an opportunity to engage with a far broader audience than necessarily what we can do when we do the normal kind of village hall engagement events. So I think we do need to take the opportunity to be really creative, be open to new ways of working, and the team are working through what that might look like, and we're engaging with the Consultation Institute to get some advice on how we best engage with the public in this.
Okay, thank you very much.
Thank you. Paul.
Thank you, Chair. Yes, Hugh, looking at the timeline on page 8, you caveated at the bottom on the basis that the timeline is subject to definition and impact of the engagement process, etc. But I think it would be useful to have an indication as to when we're going to be able to populate that timeline with some actual dates as to when each stage is likely to be reached. So could you give an indication as to when we're likely to be able to at least outline when the timescale for the different steps? And secondly, an assurance that the board will, that at each stage the board will have sufficient sight and opportunity to consider each issue as it arises, rather than it simply being there for the board to effectively rubber stamp. And sorry, one unrelated question is in relation to you in answer to Maynard's question about professional advisors. You explained the process that was gone through. We have had some issues with at least one of the professional advisors in relation to Glangwili, and perhaps you can just deal with a concern I might have about what assurance we had about the performance and learning from the issues which we experienced in Glangwili, so that they're not repeated on this project.
Thank you, Paul. Just in terms of timelines, I didn't include the timelines on this. They can be circulated after today, so we do have those timelines. There's a clear project Gantt chart that will outline the critical timescales. In terms of your point about bringing to the board in a way that allows engagement and not rubber stamping, I think part of the challenge we've had this year clearly is that the board agenda has been very crowded with our immediate response, and I've been very conscious and mindful of that. I think as we get into the recovery phase and recovery stages over the next few months, I think there will be further opportunities for us to be engaging with the board, both in seminar and in formal board. And I think that it's important that we seek a wide range of views and absolutely make sure that this isn't seen or is a rubber stamping exercise. That's not the intention at all. In terms of the learning from Glangwili, so absolutely that's been embedded into the process, and the project infrastructure that's being put in place around this programme will mitigate the issues that arose in Glangwili. And in terms of the process that we went through to approve, we sought assurances over quality, and I can assure the board that quality was a determining factor. It wasn't the tendering process wasn't a race for the cheapest. It was a balance of financial and quality.
Thank you. Are there any other questions? I'm going to bring in Steve, if I may.
Yeah, thank you, Chair. I'm really great to see this. I guess the first thing to say in all of this is I'm really grateful to Hugh for picking all of this up, largely on an interim basis. It is remarkable how much progress has been made in the light of the pandemic, and also because Hugh is also trying to do his normal exec role as well in all of this. So very grateful for that. It is really good to see this here today. Whilst we are absolutely, as the Chair said in her opening comments, still very much in the grip of this pandemic, having hope for the future, I think, is going to be so important as we start to come out of the other side of this. And as Hugh said, we do have an opportunity here, a once-in-a-generation opportunity to do something which is really quite unique. And just sort of rounding off some of the comments that were made, the board members will remember back in the September and November 2018 strategy updates, transport, recognising the unique challenges and opportunities in a place like West Wales was absolutely one of those recommendations. That is going to be a challenge to get right, but it's something that we are absolutely determined to do. But also we want to involve everybody in this design. This needs to feel like, in the end, it's a hospital that is owned by our clinicians, by our frontline managers, by our support staff, and indeed by the board. I mean, I would say, beyond rubber stamping or assurance, board members who you walk around, you see what's happening in our current systems. You can bring that experience to bear as well in helping to design this. I think we are all part of the process. Of course, we've also learned a lot during this pandemic, and the Chair and I were talking about what we'd seen in the field hospitals, for example, around the sort of therapeutic environment, the very rounded environment that's been achieved in those field hospitals, and thinking about the repurposing of Glangwili and Withybush, some real opportunities there to take some great learning, some really good feedback from the public about how we can do those sorts of things better. And of course, the need for flexibility. If the pandemic has demonstrated anything, is the need to ensure that our services can flex, that we can separate, that we can expand things like ICU when we need to. So there's a huge amount of learning there, and again, part of the unique opportunity. And making it kind of uniquely West Walian, we do absolutely need to involve the public at all levels in this, because our clinicians will clearly have expertise, as will people from around the world who design these things, but our public knows how it feels to be at the sort of the receiving end of our services, and therefore we need to ensure that what we build here is something which feels West Walian, that is based much more on wellness. Sophie Howell, the Commissioner at our last meeting, was talking about Bromley by Bow, which of course we visited as a team with others probably about 2 years ago now. What was remarkable about that, admittedly on a much smaller scale than we're thinking about here, is it didn't feel like an institution, it didn't feel like something which didn't belong to the community. It was absolutely part of the community. That's the sort of vision I think we need to bring to life here. And we want everyone to be involved in that, our children, those with maybe sensory impairments, people who have particular challenges, but also our wider population. And of course, we've got the opportunities around digital now, which perhaps we haven't seen as clearly as we have in the last 12 months, which will link to our transport aspirations to actually make this something which can be vibrant for the next 30 to 50 years. So it is great to see it here. It's great to see that despite everything else it's been developing in the background. It has probably, in all fairness, been slightly delayed by the pandemic. I would have hoped we'd be at sort of land acquisition a bit earlier, but the fact that it's still in this financial year, or in this year, this calendar year rather, I think is a testament to the work that's going on in the background. But I'm looking forward to this being a really central part of our work now as a board in the next few years.
Thanks, Steve. And can I agree with everything that you've just said? And Hugh, thank you to you and the team, particularly because it is an interim post and it is in the middle of the, the greatest challenge the NHS has ever faced in its history. And as Phil said, it's given us hope, it's light. And I love the vision, I love the West Walian home knitted, belonging to the people and of the people, and bringing all that in. So I totally agree. The board, we need to learn from the past elsewhere and here, that we are involved with this, that we bring our expertise, because we're the conduit to the public as well. So many, many thanks. It's great. Keep bringing it back, so we can have that light.
Chair, thank you. I think as the new director of strategic planning joins, it'll be somewhat of a relief to hand this over, tinged with sadness, not to get as active a role in it, but I'm sure I'll be heavily involved.
Thank you. The board's happy to accept the recommendation, and perhaps we can have some discussions outside about how often it comes to the board as well during this process. Yeah. Super, many thanks. If we can now go on to the Improving Patient Experience report.
Thank you, Chair. I'm very pleased again to bring the Patient Experience report to board and make it available for the wider population as well. Each time we try to develop the report a little further, and this time we focused our attention in terms of the story we share around Cleddau Ward. And whilst I won't go into the detail of the report, what I am hoping that people have seen through the very brief video clip that's available is the fact that despite the difficult conditions and circumstances in which everybody is operating, we are able to connect patients and their families at times of, well, generally, but also particularly when there are special occasions, such as you see in the video clip, a birthday, and also over the Christmas period as well, which was particularly difficult for patients and their families. So I offer that as just an example of the work that we're doing. And as was referenced in the previous item, the work that we're doing in creating that additional capacity currently at the moment, and the flexibility of staff to work in a very different environment as offered through the Cleddau unit. We do receive feedback through a wide variety of mechanisms, and that is intentional, and it links into the requirements around putting things right to make communication and feedback, complaints and comments, as well as compliments, through the putting things right requirements of making it as accessible to people as possible. So any feedback that we get through any mechanism is gratefully received, whether it's positive or, as you can see, some of the feedback on page 9 of the report has been less positive. It isn't always possible to respond to individual comments back, because some of these are left anonymously, either through our call line, through the PALS team, or in fact if we receive more anonymous letters and communication. That said, we try, both through this report and by ensuring that we're putting up the "you said, we did" comments in our clinical areas, to make sure that we are demonstrating that we're responding to all and any feedback that we receive, both positive and negative. What I will say is that all feedback that is received through whatever mechanism is shared with our services, positive and negative, as I say. And I would draw your attention to one of the comments in item 6, page 13 of the report, where it talks specifically about A&E staffing and some negative feedback there. What I would say is that I've spoken to a number of the teams, and there is a piece of work that's now being commissioned around a staffing review of A&Es. the work will commence in Glangwili, and it will go across all of our A&E departments across the whole of the organisation. That isn't in direct response, but it is an additional measure that we're putting in place as part of the work that we do around the Nurse Staffing Levels Act as well. The final thing that I would like to draw to people's attention is referenced on page 16 of the report, and it relates to the Public Service Ombudsman. I am pleased to say that from April there will be new requirements around the new Complaints Standards Authority that has been introduced through the Office of the Public Service Ombudsman. We have already actively engaged with that team, and we're hoping to be able to have some soft skills training, as well as training to be made available to our staff, both frontline and our corporate teams, to ensure that we can hit the ground running with effect from April in terms of the new standards. And that the focus there will be very much about the way we adapt and adjust our investigation approach, and also the additional assistance that will be made available to staff when needing to deal to respond to issues. I'll leave it there, but I'm happy to take any questions. Thank you.
Many thanks, Andy. Jill would also like to come in and make a comment, and then I'll turn to independent members for questions.
Thank you very much, Chair, and thank you again, Mandy, for this report. I think it's always very welcome indeed at the board, and it's excellent to sort of share the experience of patients in this way. The report does also, of course, bring into it the issue around complaints, and it's always a little bit concerning to see general practice somewhere at the top, or if not at the top, as in case it was for November and December. But I just wanted to provide some context around that, and it's probably something we need to think about in terms of the report going forward, that we express the numbers of concerns and complaints as a proportion of the total number of episodes of care, because I think that would put that table in quite a different context. And whilst, you know, the 46 complaints in their own individual right are absolutely important and need to be investigated, and they relate to a number of themes such as access, attitude, and various other service issues, and they are indeed all investigated. When we consider them in terms of the episodes of care, you probably would see general practice much further down the list. But I did want to assure board members that in November, of the 31 concerns received, 22 are actually now closed, and 55% of those were closed within one day. And similarly for December, 13 of the 18 are now closed. And again, 75% were closed within one day of receiving. So we do investigate all of those on an individual basis, and sometimes that will be where there are particular issues such as access, and we will work with practice where that problem is occurring. Other times we see themes that are running across practices, such as the inappropriate labelling or the incorrect labelling of bottles, for example, sample bottles that are going into our labs, and we will then send out an alert to all of our practices. But we have a weekly concerns meeting where we review all of those, and we then have a monthly concerns meeting which looks at all independent contractors, and that feeds into the primary care quality and safety process that reports into our board and subcommittee arrangements. So I wanted to provide some assurance that all of those 46 are treated very seriously. Whilst they are within our independent contractors, they are properly reviewed within the health board, but usually dealt with on a very quick basis. Thank you.
Thank you, Judith. That's very enlightening and assuring. I don't know if, sorry, thank you. Judith, did you want to come in on the same issue of GPs? Or some other part of the report?
No, I did want to comment on that. I have got another question as well. I can do both if that's okay. Sorry to everyone else. First of all, I think I would like to thank Jill for that. I think the other thing is I'm really pleased to see we are including the concerns that come in from GP practices and primary care, because I think, you know, we were a little bit disjointed with this, and whilst I do take Jill's point about volume, I think the fact we are showing this now does, I think, indicate to the public that actually they do go somewhere, because I know talking to people sometimes they think they complain to practice and nothing happens, but actually there is demonstration that when they do come through to the health board, we are recording it, and, you know, as Jill said, we are responding. If I maybe cheeky and ask the other question, which isn't really a question, but Mandy, you know what it's like. You develop this report, you improve it dramatically, and it is improving, you know, really, really impressive. I did think when I read the patient feedback, you said "we did," which I think is great, but the "we did" is a little bit wordy and a little bit jargony. And if, you know, reading that, like the first one, I'm not sure I would think a rapid assessment unit would address the issue I raised. So it's just, it's, you know, it's a detail, but you want to improve this. I think if the authors could just maybe just think about the way they word some of those responses. But thank you to everybody who does this report, and thank you for allowing me to come in.
If I may just respond, Chair, and thank you, Judith, because I'm actually fully agreeing with you, because I think that when we're publishing this, it needs to be written in a way that anybody can understand, and that the use of jargon is distracted. And certainly I did ask for some amendments to be made before we came to this final report, but unfortunately we ran out of time. So taking that forward, we will look at that going forward for the next report, and indeed as we're publishing the "we did" responses around the sites.
Thank you.
Thanks, Mandy. If I could now go to Maynard.
Thank you, Chair. First of all, Mandy, I would echo all the thanks for the report. I think it's improved dramatically in the 12 months that I've been an independent member, and I really welcome seeing this every couple of months. It's a question really of a little bit of detail, which you may or may not know the answer to. In section 4, the patient feedback system, friends and family test, we note that there were nearly 17,000 patients who attended an outpatient consultation, and they were all invited to provide feedback. What we don't say is how many actually did provide the feedback. We analysed the responses, but we don't know whether that might be 10 responses or whether it might be all 17,000.
So I do have figures on that, actually. Thank you for that question, Maynard. This month, for the last 2 months, actually, we've been tracking and reviewing and validating the feedback that we have had. It's just under 3,000, which is representative, not as good as we have previously. We normally get about a 14% return rate on any of the surveys or questionnaires that we send out to our population who have experienced our services. So those figures are currently being validated by the patient experience manager, but I'm hopeful that when we get the new system that has been approved through the Once for Wales processes, that will again pick up. Plus as well, we're rather hopeful that as the pandemic begins to ease, we will be able to put in more feedback stations as well, so we can capture more feedback real time, and likewise, particularly the A&E areas, that we can get our happy, not happy terminals back into those particular departments as well. Just to advise, they were removed for infection prevention control reasons and for no other reasons, but it is just under 3,000 in direct response to the query that you've raised.
Thank you very much, Mandy.
Thank you. Simon.
Thanks very much, Chair. Thanks, Mandy, for the report. I'm really pleased to see that we've now got a greater understanding and appreciation of compliments coming to the organisation via the new mechanism. When we have the compliments, Mandy did indicate that it's shared with staff. How is that done? And basically, how is that done, and to ensure that you know, everyone sees the kind of quality care that we aspire to see across the organisation? And can I say that I was really touched by the letters, extracts, anonymised extracts of letters that appear on page 6. It just shows you the value of, you know, of the values of the health board actually being sort of carried out in you know, in everyday life. So some indication of that would be appreciated.
Yes, thank you, Simon. And I picking up the second point first, the kindness of staff really does come through, particularly not just in those comments, but actually in the video that's been collated as well by our staff, and the sheer impact that some of the responses that staff have been able to have on families who haven't been able to connect with their loved ones. So that's I'm grateful that you've acknowledged that. In terms of how we share feedback that we receive, it really depends upon how it comes into the organisation. If it's via email, the email goes direct to the ward sister, charge nurse, team leader, wherever that feedback is directed at, and is asked to be shared across the whole team. It's through our big thank yous, so they get thank you letters and recognition back to the individuals. Plus, as well, we're making sure that through meetings such as the professional forums, the senior nurse midwifery team meetings, out to the wider variety, we make sure that the relevant exec lead also has information. If it's coming back in through PALS or through other mechanism, there's an automatic communication out to the team as well. So they're certainly getting it, and sometimes I know they get it more than once, but that's fine. I'd rather they have it a couple of times than not at all.
Thank you. Owen?
Thank you, Chair, and thank you, Mandy, for your clarification about de-jargoning the "you said we did" elements. I think that's very welcome. The clarity of communication there will, I'm sure, be appreciated. My question relates to page 12, I think it is, of the report, and the paragraph there refers to the information being available on a real-time basis and teams being able to access it and respond accordingly. I just wondered if we know how we know that is actually happening, and are people able to deal with that with everything else that's going on, particularly at the moment?
Thank you. Yes, staff are able to access it. I couldn't give you a detailed description of that, but what I can say is that the teams are able to go in, they are able to have real-time access to what's being said. That is going to improve and strengthen, and if I was, I wouldn't want to mislead you and say that they're looking at it all day every day, but certainly the work that the flows are doing, the family liaison officers, the work that the patient advocacy and liaison team are doing, that the concerns team are doing, is making sure that there is, if not looking at it on a real-time basis, and we do monitor it, we do look to see who's accessing the responses through the corporate team. They will go and engage directly with the various teams or the senior leaders of those service areas and have some real-time conversations about what is being fed back.
Okay, thank you.
If I could also add to that as well, the Listening and the Learning Committee considers some of that information which may not be real time, but any themes, and that empowers the teams that you've just described to go back on behalf of the committee to scrutinise whether there has been changes and improvements. If I could now go on to Delith, then Paul, and I think that, and John.
Diolch, Chair. Mandy, and maybe you can illustrate for me what is happening about customer service training, because as we know, communication with our patients and relatives is key. How are you envisaging assisting staff to deal with this issue during this terrible time for the staff as well? And what are you going to roll out customer service training for community and GP settings, for example? And then there was a second question about flows. I noticed that you are reviewing the way that flows work. What are your current plans for more work for the flows? Thanks.
Thank you, Delith. In terms of customer care, as you will appreciate, we've been a little delayed by COVID in terms of some of the initial plans that we had to do some rollout. But there are links being made through Lisa Gosling and also Christine around some of the work that we can, some of the more work that we can do. And we are going to link it to the rollout of the implementation of the charter that the board will have had. Recall that it's signed off and agreed, or rather approved and supported last year. So that will dovetail in. We're looking, hopefully COVID dependent, that we will really kick that work off in earnest by April-May time, so certainly Q1. We've also been engaging with some colleagues in Northumbria, because obviously they've done some exemplary work around customer care training, and I think that that's really important that we look outside the organisation and further afield outside Wales as well. So those links have been made, and one of the staff from that team have said that they're more than happy to come and work with one of Lisa's team and my patient experience team to actually look at how we can be supported to take that further forward. So hopefully that addresses the customer care training. And I think just an additional point, it's not just about classroom training, helping we're going to have to look at how we do it in a much more dynamic way. In terms of the family liaison officers, Louise has been working with a variety of departments, both internally, but also looking at what we can do with third sector providers as well. So I know that she's also been working in collaboration with our commissioning team to look at the art of the possible. We are taking some information through to Quality Committee around a possible model, and it is a possible model as to how we may be able to go forward. And I'll also be taking that for discussion with my exec team colleagues as well, because obviously this doesn't come without a resourcing requirement. And before we go any further forward, we need to understand what is it that the family liaison officer structure needs to look like in a post-COVID world, because what we've required during COVID and what we will require post-COVID will hopefully, with visiting changes, will need to look very different. So there are certainly plans there, it's been modelled through and different options have been explored.
Thank you. So I'm going to go to Paul and John.
Thank you, Chair. Mandy, you've highlighted in the report that we've had 4 Ombudsman's reports in the last period where the complaint has either been upheld or partly upheld. Obviously, we look at the detail of those reports in the listening and learning group, but 4 in the period of time since the last report is quite a significant number. Is that as a result of the Ombudsman's sort of backlog in his work, and are there other cases in the pipeline which we need to be aware of?
Thank you, Paul. Yes, my understanding is that the Ombudsman had held back on issuing a number of reports, and like all of us, they had been affected by COVID. So we are seeing a backlog, the results of the backlog now being tackled. We certainly, from the liaison meetings that I have regularly with the officer from that from the Public Service Ombudsman, there isn't an indication that there's any increase expected. And in fact, the type of reports that we're getting, particularly around complaints handling, have continued to diminish. So although you saw a number in the last period that appears to be higher, our anticipation is that we will remain fairly stable, and if anything, we're expecting to see an overall reduction again this year compared with the previous year, which again saw a reduction on the previous year itself. So I do think it's a backlog. But if there is any change in that, or any sense that we're going to see a continued climb, then I will report back accordingly. I think it's just important to remember that regardless of the robustness of any complaints process, individuals have the right to go to the Ombudsman and for it to be reviewed. But obviously we work very closely with the Ombudsman's office to make sure that we're aware of some of the issues up front, so that we can actually put measures in place to try and address those rather than just wait for a report to land.
Thank you. John.
Mandy, thank you for the report. My key question for me, understandably our patients are anxious and concerned about waiting times as a consequence of COVID and restart of services, and that seems to have been a theme within the complaints. I guess I'm just looking for some assurance that we've got mechanisms in place to communicate with our patients and also reassure and explain to our patients why we're in this particular situation, challenging situation.
Thanks, John. Some of this is being managed through our routine communication with our public in terms of keeping people up to speed with where we are. Scheduled care is the one area where obviously people are particularly concerned because they're on waiting lists. And I think the work that we're doing through the single point of communication, so transferring from our COVID command centre into a longer term communication hub will actually be a mechanism through which we can provide that assurance on a longer term basis and direct communication with patients. So we are communicating with them, and if I think particularly around the orthopaedic team, for example, the consultants have been asked and have worked through the process of communicating directly with patients who are sitting on waiting lists there, so that they can be assured as to what's happening with their care, when they can expect to be receiving further communication as well. So it is work in progress. There's always more that we can do to communicate with people, but certainly we're looking at different avenues and making sure we use general comms through to specific bespoke engagement with individuals.
And if I recall rightly, that's going to be considered at Quasiac in April, the updates on the matters at the beginning of the board. Thank you. Well, on behalf of the board, can I thank Mandy and the team, particularly at the moment when it's independent members are restricted from meeting patients and meeting staff, that it's so important that we have the patient voice loud and clear at our board today. So many thanks. And there's one of the comments in the meeting chat, which was from Anna, and it was about really welcome, as we all do, the reviews in A&E, the staff and reviews in A&E. In our pre-meeting, Michael said that this is a lightning rod, what people say, to enable us to look where we need to assist and support and improve. And by doing that piece of work, we really, really welcome that in conjunction with Lisa's team. So many thanks, and could you pass our thanks to the team, Mandy, and this will stay central to our board reports. Yeah.
Thank you.
Okay, next item on the agenda is the COVID-19 report. And I don't know if you take this.
I'm taking it, yep. I was waiting for the pass. yeah, thank you for this. And I think it is a measure of just how fast the pandemic's moving, that even this report was written a couple of weeks ago. I was updating yesterday for the board today, and indeed even this morning things are further updated. But as I say at the beginning of the report, since the time we last met in public, the progress of the pandemic has changed quite profoundly in a number of ways, both positive and negative, and things continue to move really very quickly. I guess the first thing I would want to acknowledge is that over that period of Christmas, since the last time we've met, I think our staff have probably faced their most difficult moment of this pandemic so far, both personally and also professionally. And I have to say I've been hugely moved, as I think we all have, who've been able to see the work of the organisation, hugely moved by the courage, the compassion, professionalism and the kindness that we've witnessed across the organisation despite the pressures that our staff have been under. The number of people who've been needing our care has been much more than double the amount that we saw in the first wave back in April and May. And tragically, we've seen many more people die in this winter wave than we did in the first wave. The latest data I have is 276 further deaths since this wave commenced in around October versus 68 in the first wave. And as well, of course, as that being a tragedy for their loved ones, for their families, it's also taking its toll on our staff on the front line who are experiencing this. And I think, one of the things I know is on all board members' minds, and is something we need to give very clear thought to, is the legacy that this pandemic will leave behind for the health and well-being of our staff as we move into recovering, rebuilding, and building for the future, as we heard earlier around our strategy. On a positive note, despite this having been a really challenging period for everyone, we are seeing, as a result of lockdowns, that our infection rates are starting to fall. Even actually since this report has been written, where the scale of the fall in infections in our communities are seen on the table on page 2. The very latest position, which was published by Public Health Wales today, shows that a further drop has happened. So overall for the Health Board, the infection rate up until the 23rd, that 7-day period, is 156 per 100,000, down from even the 267 that I was reporting in the report for the 9th of January, and our positivity rate is at 13.2. course, this is starting to be reflected in our hospitals. The numbers of COVID patients, both confirmed and suspected, remains high by historic standards within this pandemic, but they are starting to fall. And at the end of my preamble, I'm going to ask Andrew just to give an update on the operational position as it stands today, and also Mandy on the outbreaks that we see, because we know there is a very strong correlation between outbreaks in our hospitals and the level of infections out in our communities. Equally positively, and actually a change, a significant and profound change since the last time the board met, is we now have vaccines. We didn't have those at our last public meeting. As of this morning, and I'll ask Ros to give the latest position on this as well, but looking at the data through the national system, we're now approaching 10% of our population having been vaccinated since the last time we met in public. 37,881 people. A monumental task, I think, over that short time scale, but need to recognise the amount of concern out in our communities and indeed for our staff, as I've reflected in the report, about the desire to get vaccinated so that we can all start to see a light at the end of the tunnel. I've seen every day the ramping up of our vaccine strategy, the opening of 6 mass and the mobilisation of all 48 practices, which, whilst has complex logistics in it, I think very well matches the rural nature of our population and enables people to get their vaccinations as close as possible to home. Of course, we have the additional challenge of vaccine supply, not just in total, but also the balance between the two types of vaccine, which have very different handling and logistic characteristics, and the need to establish mass vaccination, in particular for the Pfizer vaccine, which doesn't lend itself well to being distributed out to our general practices. The other thing I acknowledge in the paper is the changes from the Joint Committee on Vaccination and Immunisation, and indeed supported by the 4 Chief Medical Officers in the UK, around the changing to the dosing schedule for, in particular, Pfizer. And there's the supplementary paper that I'll ask the medical director to cover when he comes in. The paper gives a bit of an overview. Hopefully that helps. If I can ask firstly Andrew to give an update on operational position, then Mandy on outbreaks, Ros on vaccinations, and then perhaps Phil can cover the second dose issue. And Phil, if I can ask you in that, because I forgot in my chief exec's update to also update the board on TAVI, and then I'm happy to take some questions.
You see, Andrew. Are you able to hear us? Okay, if we go to Mandy, and then we'll go back to Andrew. Mandy.
Yes, certainly, thank you. In terms of outbreaks, we've been on a bit of a roller coaster, I think it's fair to say, but I'm very pleased to be sitting here today and report that at the moment we're managing 4 outbreaks across the whole of the organisation. So we're very fortunate that the staff have responded extremely well. They've worked collaboratively with colleagues within Public Health Wales, our CCDC who supports us, microbiology, the infection prevention control teams, and importantly the operational teams who are in the thick of it, managing patient care on a day-to-day basis. So we've been extremely fortunate to have weathered what has been a particularly difficult period for both staff and patients, and importantly their families as well, to come to a position. The one area that and it's been touched upon in previous reports, that I remain concerned about is the position in Glangwili, and that is because of a number of issues that we've touched on already, predominantly around our environments of care and the infrastructure activity that we need to be able to resolve some of the long-standing issues there. Regardless of that, though, we see in Withybush and South Pems at the moment the activity linked to outbreaks there directly correlating with our position in community transmission. So I'm expecting that to improve as well. along and hopefully get to the position that we've got in both Prince Philip and Bron-Gleis, where as I sit here today we have no outbreaks being managed, and I think that is testament to the staff's commitment to good infection prevention control practice. Overall, though, as I say, the areas that we're remaining extremely focused on are around our environments, and particularly our cleaning standards across all of our sites. Ventilation, making sure that all of our areas are ventilated, and I was talking to staff within the field hospitals about the processes that they've put in place there to support good and effective ventilation in those areas. Continued adherence to our protective measures, particularly around PPE, hand and respiratory hygiene, and also social distancing, which I'm pleased to report we check upon each and every time that we have an outbreak meeting. But importantly, we're also now recommencing the ad hoc audit and face-to-face inspection work that we were doing previously. It has gone on throughout the pandemic, particularly in outbreak areas, but we're picking that back up again as well to be able to make sure that we're absolutely on top of it and that we're sharing learning each and every time we come across an opportunity where we think we can do something even better than we're doing now.
Mandy, that's an excellent update and really assuring. Andrew, sorry you had technical issues.
No, I'm sorry. I didn't have stage fright. I just want to reassure you. I don't know what happened then. As I clicked on my camera, it just cut me off. Thank you, Chair. I think I just wanted to echo what Steve said, which was the period since our last board meeting has undoubtedly been the most challenging for us operationally in the organisation and our local response to the COVID-19 pandemic since last March. I think the complexity of trying to maintain safe green pathways and manage the red COVID pathways in line with the infection prevention and control advice, together with the impact rising community incidents had on our staffing availability, has been a real challenge for all of the operational services during this period. After the fire break, we had started to see a gradual rise in community incidents and hospital admissions, but through November and December that became more of an exponential growth, which peaked on the 13th of January for us, when we had in excess of 250 patients either confirmed or suspected of COVID-19 in our acute and community hospital beds. By comparison with the first peak, that figure was closer to 120 patients in the first peak of the first wave. So as the Chief Executive said, we more than doubled our position during the second wave. The position and impact the increased incidents had on our staffing availability was a real challenge, and at various stages through the last 2 months we've had on average as many as 1,000 staff absent and on leave, many of which were either isolating themselves having contracted COVID or as contacts of potential contacts of people that have had COVID, and that number of staff is roughly double what we would normally have to manage with in terms of absence during this period. So that in itself put a significant pressure on the capacity and our plans and our response plans that we'd put in place. We've seen that pressure as well across the whole system. That's not just been acute and community hospital pressure. We've seen it in primary care initially as the community incidence was rising. We've seen it in our community services, and we've also seen it and still experiencing it to a degree in our social care and nursing care settings, where we've still got a number of homes that have that are either close to admissions at the moment, having had COVID positive patients or outbreaks, which continues to put pressure on as part of that system that continues to have add to the pressure that we're facing. I think in December, due to that exponential growth we were seeing, and in particular as part of that growth we were seeing a level of acuity that we didn't see in the first wave, and a level of pressure on our ITU services that we hadn't experienced but had been evident in other parts of Wales during the first wave. We did need to go through the process of creating some additional surge capacity, and it led to us having to take the decision just before Christmas of delaying all of our elective surgery, where in the view of our clinicians, a delay of 28 days would not have an impact on the outcome of those patients. It effectively meant that for 3 or 4 weeks, all we've been able to provide in elective care sense is emergency, or planned care sense is emergency surgery and semi-emergency surgery, if you like. We've been unable to do the level of urgent and cancer work that we would have wished, and that was part of our original Q3 and Q4 plan. That was a really difficult decision for us to take as an operational service and a health board, and it was very much a last resort. But without making that decision, we would have been unable to have redeployed staff across the health board to support our ITU capacity, bolster our acute and community hospital capacity, and also support the field hospital capacity, which has been really invaluable during this period in managing the demand and flow of patients through the system. I'm pleased to say that in the last 2 weeks, as the COVID position has eased somewhat across the health board, we have been able to restart that urgent cancer work in Glangwili and Bronglais Hospital. There is a plan to restart it in Prince Philip from next week. And we're also working on a plan that would mean from the 8th of March in Prince Philip, we would establish an enhanced post-operative care area that would enable us to increase the level of urgent cases that we're running through the Prince Philip site. So that's a positive development. As the position in Withybush improves through the coming weeks, we will look to follow that plan around the PACU in Prince Philip there to enable a restart of our urgent cases in Withybush. In the meantime, we're trying to use our sites and capacity to manage in clinical priority order, the cases on our waiting list. So that may mean some patients are offered the opportunity to have their treatment or surgery on a site that maybe they weren't expecting to, possibly with the original receiving consultant, or maybe with the local team if they maybe end up being transferred to another hospital for that treatment. But we're doing everything we can to maximise the capacity we've got available to us to treat those patients that are waiting. And through March, we're anticipating, therefore, that we will get back to delivering the elective plans we had in our Q3 and Q4 submission that we brought to board in the autumn and that we submitted to Welsh Government. In terms of where next, the modelling indicates that we are probably past the peak now. It didn't come uniformly, and Pembrokeshire saw a peak slightly later than Carmarthenshire and Ceredigion. But the modelling is indicating that we're now on a downward and positive trend, as per the Public Health Wales data this morning. I think we're still trying to understand the impact the vaccination programme may have as we go towards the spring on our potential numbers, and also obviously what any lifting of restrictions over the coming weeks and months before that vaccination programme has fully been implemented will have on our potential demand. We know from past experience that as we come out of lockdowns and restrictions, that lifting restrictions can see an increase in transmission and therefore hospital admission again. So we will be keeping a close eye on that. But the signs are within the modelling that we're on a more positive trajectory, albeit due to the length of stay and the added acuity we've had, some of the bed occupancy numbers may remain high, although stable for 3 or 4 weeks yet. Finally, I wanted to reserve my final comment, if I may, for our brilliant staff. I think the courage, commitment and determination they've shown over the last few months, I know I personally find totally inspiring. They faced some very difficult and dark days and nights, often coming in not knowing whether they would have a full complement of staff working with them on the ward, or even if they would be going into work on the ward that they would normally work on, or be redeployed elsewhere in the hospital to support other areas that were struggling. The way they've supported each other and the kindness they've shown to each other and the population in helping us to deliver our response is truly fantastic, and I know I can't thank them enough for all they've done. So it's important, I think, that I just wanted to make sure I finished on that point after what we know has been a really difficult period for everyone in the region. Thanks.
Thank you, Andrew, for your really sincere thank you to staff, which every single one of us here totally agree with. So thank you. I'm going to go over to Ros now, and I've asked Lisa if she'll come in to give a brief update on workforce after FIP. So thank you.
Thank you, Chair. I'm apologising right now if I just repeat a couple of things that the Chief Exec has already mentioned about the vaccination programme. I don't know how he does it. I think he must check my notes prior to coming online, but I'll try to be as succinct and with new information as much as possible. So we are really fortunate here in Wales, as we're currently deploying both the Pfizer-BioNTech and AstraZeneca vaccine, two really effective vaccines across our population. And we really are gaining momentum in line with vaccine supplies, both for the Pfizer vaccine and AstraZeneca vaccine, as they are increasing in dose numbers coming through to the Health Board. Now, the pace and scale of this vaccination programme is incredible, but it needs to be, in terms of us wishing to be able to protect as many people that have been prioritised for the vaccine by the Joint Committee for Vaccination and Immunisation as possible. Now, these groups have been identified by this body, the JCVI, which is our expert vaccination and immunisation panel for the UK, in priority order, groups 1 through to 9. And they've been identified in that order due to the risks that to those individuals from COVID-19 in terms of very serious illness and tragically even death. So very, very poor outcomes from COVID has meant that they have got a position on this prioritisation list by the JCVI for the first phase of this programme. And if we vaccinate, and all of those individuals identified on that list actually covers about 99% of those we know through this pandemic have been at serious risk of poor outcome. Also, over the last few weeks, we've been learning so much about both these vaccines in terms of how we can deploy them. So Steve's already mentioned that the Pfizer vaccine does pose a number of logistical challenges. It's an absolutely great, effective vaccine, but it does pose a number of challenges in terms of deployment with regards to reconstitution, around its storage temperatures, its batch sizes, and how we manage waste with regards to the shelf life that we have with the Pfizer vaccine once it's been reconstituted and we are holding our clinics. And that really lends itself, therefore, that vaccine to large mass vaccination centres across our geography. The AstraZeneca vaccine, again, another excellent, effective vaccine, being that it arrives in much smaller batches, its storage temperatures are much easier to handle vaccine, and it has a much longer shelf life than the Pfizer vaccine because of those storage properties. Again, then makes that much more adaptable for distribution across our primary care services to be able to reach our population in smaller but more frequent clinics. So we might have enough vaccine for our groups as defined by the JCVI coming through to Hywel Dda, but of course they are split between these two vaccine types. And so we are having to be extremely agile to be able to adapt to the supplies coming through to the Health Board area in terms of making sure that we are able to reach as many people as fast as we possibly can across those priority groups with the vaccine supplies that we have. So we've been having to make a rather unprecedented step over the last week to 10 days with regard to the deployment of a Pfizer vaccine through mass vaccination centres to our population. So we're normally, as a Health Board, very active with regards to the vaccination of workforce and staff and we have been doing that since the beginning of December with regards to those members of staff and workforce identified in that prioritisation framework by the JCVI, namely staff that work in care homes and also our health and social care staff, our frontline staff that are supporting our members of the community through this pandemic. We also are very good at delivering the vaccine to children within our school nursing services. Now, because the prioritisation framework is very much related to age and the older population being most at risk, and also those with underlying health conditions, we're redeploying all of our very experienced vaccinators into our mass vaccination centres so we can reach those the population. So at the moment we're really having to deal with that split in that vaccine, and over the coming week we're going to be opening our mass vaccination centres right across our geography to be able to support a population group aged 75 to 79 to be able to access the vaccine in line with the supplies that we are receiving through to the health board area. So we are really are maximising all of our vaccination teams to be able to reach as many people in the order that has been described to us as part of that vaccination strategy to our population as best as we possibly can.
Thank you. That's an incredible achievement by everybody. Massive thanks. I'm going to bring in Judith and Michael for questions. Judith?
Yeah, thank you, Chair, absolutely, and thank you, Ros. Very comprehensive, and I think it's remarkable what everybody's doing. My question relates to something I haven't been able to find in any of the documents about people with learning disabilities. And whether that's people who are living at home or whether in group homes or care homes, I don't know whether they are in that high risk group or whether there are specific arrangements for people with learning disabilities which we know are at particular high risk.
Yeah, so the care homes that are defined in priority group 1 are very clearly for older adults, and that is again in line with the fact that the gravest harms and risk of poor outcomes from COVID have been very age related. So that is the reason why they've been in priority group 2. And homes specifically or care services specifically for those with mental health and learning disability needs aren't currently in priority group 1, but that particular group would be captured in terms of if they're extremely clinically vulnerable, they would then be in priority group 4, and if they were at risk for any other reason, in priority group 6.
Okay, can I sort of follow up? Do you know if that's going to be reviewed at all? Because there is quite a lot of sort of media interest around this particular vulnerable group of people.
Yes, so if they are extremely clinically vulnerable in terms of profound and severe disabilities, they will be in priority group 4.
Okay, thank you.
Michael.
Thanks, Chair. Ros, are you seeing much evidence of people refusing the vaccine?
That's quite an interesting question, actually, Michael. We're an area that has struggled in the past with some form of shall I say, vaccine hesitancy rather than resistance, although there are always pockets of those that actually choose they do not want a vaccine of any sort, and this isn't any different. But we are not experiencing the form of vaccine hesitancy that we've ever been used to in the past. In fact, the demand for this vaccine has been really incredible. We are seeing that individuals, when they're invited, and it's much easier to see when you have a cohort of individuals that are actively called in. So we've been going through a bit of a transition process as we've been being able to bring on more of the functionality of the Welsh immunisation system that we're using to record all vaccinations that have been issued. We're seeing this for the first time as we've been calling at the population group 3 the 75 to 79-year-olds, that's an active invite that goes to each individual identified within that group. And if they do not want the vaccine, they want to cancel their appointment that they've been issued for a whole host of reasons, we have given them we've got a call centre to be able to have conversations with those individuals around a number of different challenges, and they're having conversations. So we're able to have some soft intelligence really in terms of whether that's an absolute refusal. No, you can take me off your list because I don't want it. But that's not the type of response we're getting. There is a great demand out there, and we're getting very high uptake indeed.
Thanks, Ros. That's really reassuring.
Ros, Anna.
Thank you, Chair. Hi, Ros. Just to pick up on Judith's question, to follow on from that really, what kind of level of confidence have we got that in this category of people who are counted as clinically extremely vulnerable, we are catching all the right people in that group, or is there an inevitability that some people are being missed, and how can we be as rigorous as possible about making sure we're not missing people?
Actually, we were, this has been on our radar for quite a while, to be honest, Anna. We were quite exercised by this when the first initial draft prioritisation framework was sent through and issued by the JCVI, in terms of how do we really get to grips with defining this group as accurately as we possibly can. And of course, an awful lot of those have been identified through shielding and through letters that have been issued in the past during this pandemic, namely the first tranche of shielding letters that were issued way back in March, as early as that first lockdown period. But we've been refining and understanding that group an awful lot better throughout this period. And there is also additional ability for general practitioners predominantly to be able to, if they consider that they are clinically vulnerable, there is an option for them to actually add them to the list. So it's not just if you didn't get your letter in your first wave, you're not going to be on that list. We are trying to refine. We are really trying to delve into understanding our clinically extremely vulnerable population as much as we possibly can. And in order to develop the profile of the population for our mass vaccination programme, we've been liaising with primary care to be able to access as much information as we possibly can on this group.
Thank you.
Ross, I'm going to bring in Jill, and then after Jill, Simon. Jill?
Can I do it?
Thank you. Yes, sorry, waiting for the mute button. I just wanted to finish this section probably on a very positive note, and to thank everybody in general practice really for the extraordinary work that they have done over the last 2.5 weeks. By the end of this week, we will have vaccinated 92 out of our 98 care homes fully, and we expect the other 6 that we're waiting for, which are currently care homes with some restriction because of COVID outbreak. There are dates going in the diary for those remaining care homes to be vaccinated. So 2,360 care home residents have been vaccinated, with a further 254 left to complete. And of our over 80s, we've vaccinated well in excess of 12,000 over 80s. And again, we expect that programme to be completed for priority groups 1 and 2 by the end of this week or early next week, as we then start to move, as Ros said, to priority groups 3 and 4. So really, just as our teams in our mass vaccination centres, we extend our great thanks to general practice for the extraordinary work that they're doing at this time as well.
Thanks, Jill, and the whole board echoes that. That's a phenomenal achievement, and particularly because we know how vulnerable people are in care homes and how vulnerable people over 80 are, and they've been living with that fear for such a long time. So thank you on behalf of the board to all our GP practices who stepped up immediately 100%. And you know, some of the discussions about mass vaccination, our real mass vaccination, is through our GP practices. Thank you. I'm going to bring in Simon.
Thanks very much, Chair. Can I associate myself with the comments that have been made before? I mean, the staff have responded magnificently, as always, to this unprecedented public health emergency. Just a question, really. I know this is determined by supply issues of vaccines, but what kind of planning, what kind of dialogue or discussion are we having with community pharmacies? And I just perhaps a question for Ros. What do we see as the role of community pharmacies in terms of the vaccination programme? Thank you.
I'll put that to Jill.
Okay, thank you.
Yeah, thank you very much. Welsh Government issued a set of directions just before Christmas called the Primary Care COVID-19 Immunisation Scheme, and that did extend to all of our independent contractor professions, so GPs, community pharmacies, dentists and optometrists. There wasn't an expectation that dentists and optometrists would be able to engage through their own practice, but there's an opportunity later on to consider their support through mass vaccination centres. But directions have been now established to allow community pharmacies to directly receive stock. But of course, what we want to do is to engage community pharmacies in a very well-ordered way so that it's not a free-for-all, and that, as Ros has said, we clearly know which groups are going where at which point in time. We have written out, as we were requested to do by Welsh Government, to ask all of our community pharmacies, there are 99, who would be interested in supporting this programme, and a significant number have responded, and some have already undergone training because they do vaccinate for flu. So we're working with them now and Welsh Government to look at the next phase. We've already allocated, as Ros has set out, all of our priority groups 1 to 4. So as we plan for priority groups 5 to 9, that's when we'll be having a further conversation with our community pharmacies as to how we engage them in undertaking this massive challenge. So their response is very welcome, and we are communicating with them to know that we are going to be working with them in the very short future.
Thank you, Jill. Ros, could I ask a question for assurance for the public? And it was very clear that the AstraZeneca is with the GPs and Pfizer, because of its properties, is in our mass vaccination centres. And I know some discussions have been going on for those people, the 74 to 79 age group, who may have difficulties in getting to the mass vaccination centres. I wonder if you could just enlighten us on where those discussions are.
Yes, so thank you, Chair. Over the last because this was quite an unprecedented step because of the split between availability of Pfizer and AstraZeneca. We made this decision to be able to open 6 mass vaccination centres across all of our geography to try to ensure that we are reaching as close to home as we possibly can do to our communities. We realise that the large centres, such as we need to deliver the Pfizer vaccine, are not on the doorstep as much as primary care, and that is why our model is very much reliant on the amazing job that primary care can do to deliver the vaccine. But we have to deliver what vaccine supplies that we get in a timely fashion to those most at risk. So this is an unprecedented step with regards to mass vaccination centres, and we realise that there may be some difficulties for members of the public, particularly within that older age group, being able to perhaps access through via their own vehicle. They may not drive, they may not want to drive at darker periods of the day. There's a number of different issues and worries and concerns being raised through our call centre in terms of why there may be individuals a little bit worried about being able to go into those mass vaccination centres. So over the last 2 or 3 days, we've been having some very robust conversations with our partners across the public sector as well as the third sector, a number of which are on the call today at the meeting today, really trying to think as broadly as we can to be able to support and enhance services that are already in existence with regards to our public transport system and other systems that we have to enable individuals to, through community services, either reach public transport mechanisms or actually be taken directly to the mass vaccination centres. So our work at the moment is to try to bolster and boost some of the services we already have for the population in those more remote areas of our geography. and we're getting some fantastic response from the voluntary sector in terms of what they can step up to be able to support this effort, as well as some of our public sector organisations such as the Welsh Ambulance Service and also the Fire and Rescue Service. So we're just finalising some of those details, but our call handlers within our centre that are receiving some of those worried calls are able to be offering some support and advice already, and that has been happening and referring through to some of those support mechanisms over the last couple of days.
Thanks, Ros, and I expect there to be a communication to the public about that once as the plans get more and more firmed up. Thank you. I'm going to bring in Lisa now to give a very brief update on workforce, and then Phil.
Okay, thank you very much, Chairman. Just before I give an update on the recruitment position, linked into Andrew's comment about thanking our staff, can I also extend a massive thanks to all of our corporate functions? They're always the teams that are invisible within the health service, but we've actually seen members of those teams working in vaccination centres. We've seen them supporting occupational health services, and the recruitment numbers that I'll go through now in terms of our workforce and OD team, they have been phenomenal. Would also like to thank our volunteers who are still with us, and they are still doing fantastic things to support our staff. If there was ever a time when the three parts of our organisational values ever came together, this is it. Everyone is striving for excellence. Everyone is putting the person at the centre. So, you know, I just can't thank people enough. So moving on to the recruitment position, our recruitment team normally handle 2 mass recruitment events a year. So that would be our apprenticeship programme at the beginning of the year and our newly qualified nurses towards the autumn. In the last 12 weeks, we've appointed 1,025 people. We have had a few people withdraw, so we've lost 150 due to personal circumstances, some of those that were linked with changes to school provision, etc., so people couldn't continue. So 871 have been appointed in the last 12 weeks. 451 of those are already in our hospitals, field hospitals, vaccination centres, providing support to our patients, and that includes domestic supporters, healthcare support workers. We have another 421 who are currently in the recruitment process, so whether that be training or the pre-employment checks, and 241 of those already have a start date and will be with us within the next 6 weeks. That includes 70 administrators for vaccination centres, 104 vaccinators, 223 healthcare support workers and 12 porters. And just to add to the scale of that, in addition to that, we also have normal recruitment taking place. So as somebody leaves and we replace, and there are 112 people that will have joined us in January and through to February. So that's in addition to the COVID recruitment. In terms of a vaccination update, we now have 244 individuals who are fully trained and have been passed across to the rota coordinators within the vaccination centres. And we have 219 that are already on that training pathway. So a message to anybody, any of our staff listening today or any of our members of public, if you haven't heard from us yet, we are working through all of the numbers. We've got lots of people who are still interested in joining us, and we can't thank the public enough for their support. Please bear with us. We will be getting in touch with everyone as soon as we can. Just to add to that, we have an advert that is live at the moment as well for hotel facilities staff, so cleaners. Closes on the 1st of February, and to date we've had over 240 applicants. The process that we now have in recruitment is the day after it closes, we then begin our interview process. And the family liaison officers that Mandy talked about earlier was also published yesterday, so that is live for applicants now. So therefore, the other thing that the team are doing as well is the people that we brought in our first recruitment programme, so those people that started back in March last year, we're also in contact with all of those to continue to see who wants to remain with us. So we're trying to keep the existing staff that we've got, and we're bringing in the new staff. And then just the other piece of work that's not linked with the recruitment, but we are doing lots of work with our trade union representatives and with our OD team in terms of how we continually support our staff in the workplace now, and how we look at how we continue to support them as we progress through the pandemic and hopefully out of the pandemic. So there's lots of work going on linked to workforce at the moment.
Lisa, and thank you to all of you, Ros, Andrew, Jill, all the executive team. Incredibly impressive. You know, it's like at Winston Churchill never has so much been owed to by so many to so few. Absolutely and utterly amazing. And I'm glad, you know, that the public can hear this on the live stream. Thank you. Sorry, I'm going to go to Phil now, if I may.
Thank you, Chair. So I was going to pick up the ethics, the second dose vaccine paper and the TAVI update. So on the second dose paper, members will have had the report, which is extensive. A brief bit of context that vaccination development normally takes 18 months. So the fact we have a vaccine at all is an extraordinary scientific achievement, and means that we should be waiting another 9 months ordinarily to be getting the vaccine. However, as soon as the vaccine's available, of course, everybody's mind across society moves to, when am I going to get my dose? And if you've had dose, when am I going to get my second dose? And we have to recognise actually that across our staff, there's been significant concern about the change in advice around the dosing schedule, particularly for the Pfizer vaccine. The other bit of context is that the Director General of the World Health Organization reported on the 18th of January that 39 million doses of vaccine have been given worldwide in in all the high-income countries, and only 25 doses across all low-income countries. So I think it's important that we recognise the context and what an incredible achievement it is that we've given, and we've got to a stage where we've been able to give so many doses to our staff and across our population at this stage. The JCVI and CMO advice was based on two key points. One, or change in advice. One is the efficacy of the first dose of Pfizer. The fact that if you discount the first 2 weeks, because you can, if in the first 2 weeks, if you get an infection, it's before you've developed immunity, then if you discount those first 2 weeks, with the evidence, you get 89% immunity from the first dose. And the second key point, a big key point, the CMOs and JCVI changing in guidance based on, is that if you have somebody of similar risk in front of you, two people in front of you with similar risk, one who's had the first dose and therefore has 89% immunity, and someone else who doesn't have it and therefore has potentially 0% immunity, who would you give the vaccine to? Well, you'd want to give it to the person with with 0% immunity. And I suppose it depends. If you've not had the vaccine, of course, you'll be saying, well, please, could I have my first dose? If you've had the vaccine, people will say, please, could I have my second dose? The paper sets out that this is national policy, and therefore there are implications for our organisation within this. It also sets out that the range of support, the evidence behind the supporting bodies and institutions, and it also sets out clearly those links to the advice from organisations that are against the JCVI CMO advice, and it sets out the deliberations of our ethics panel. We are, I can confirm, in continued discussions with Welsh Government, and we have implemented a no wastage policy with reserve lists prioritised on the basis of the first dose wherever we can. And you can see the comms that we've done. We've done staff events on live Teams. We've sent letters to key staff group representatives. And we've also had multiple meetings with individuals and small groups, a range of us, including myself and Steve and Ros and others. But I'm happy to take any questions on that. On the TAVI, which is a brief update, TAVI is transcutaneous aortic valve insertion, which is when the board has received reports on this procedure in the past. I mention it because we have had papers from Swansea Bay in advance that they are taking to their public board today, which give an update on their action plan in regard to the reports they've received from the Royal College of Physicians last year, and also an update on waiting times. Most of their actions are complete, but it does point out that there is a further review being undertaken by the Royal College and that they're awaiting that report. And we will be taking that report to our Quality, Safety, Experience Assurance Committee in due course. But happy to take any questions on either item.
Thank you, Phil. Thank you very much. I'm going to bring in Anne and Paul.
Thank you for that, Phil. But my question is for either Steve or Andrew. What information do we have on the Valero shutdown in Pembrokeshire, where there's an estimate of about 4,000 potential employees are expected to work on the shutdown site? And are we having any communications with them at this time?
Yeah, thanks, Anne. I'm gonna hand over to Ros. Apologies, I know you've asked these questions of me. I hadn't got back to you when we last spoke. I did speak to Ros yesterday, but I thought I'd let Ros describe the really good work actually that's gone on with Valero.
Thank you.
Thanks, Anne, for raising the question, and a really important one with the such large numbers of individuals due on site for an extensive overhaul of the facility. We've known for some time. This has been raised through, first of all, the IMT process, so the incident management team structure that we have across all three counties from a COVID response perspective. This was raised some months ago in terms of highlighting the work that was going to be planned for the tail end of this financial year and into next. So we got early sight and we started very early communications with the Valero organisation in terms of how we might support the preparations and the planning for such a large number of individuals coming on site from a COVID-19 management perspective. So those conversations have been detailed, they've been frequent, they've involved site visits, understanding risk assessments, understanding mitigations and planning in terms of how that can be best managed over that time period with such a large number of people. There is even plans for site presence from the TTP team through leadership in the regional response cell that we have here at the Health Board from a public health perspective in terms of direct communication and presence on site. It really is an intensive support package that's been put in place to try to manage this large-scale movement of individuals in and out of our county area.
Thank you very much. It's reassuring to know.
And the last question is from Paul. It's in the message bar. Paul wants to ask about the prioritisation of unpaid carers and, subject to the answer, how they're being identified.
So I might attempt a bit of that because, again, Ros and I talked about this yesterday. We've had some queries and Ros might want to come in on some of the detail, but generally, Paul, the priority is to stay within the priority groups in terms of vaccinations linked to supply. However, there is flexibility for both mass vaccination centres and indeed for our GPs to make judgments. So where a carer is bringing in the person they're caring for because they're due for their jab, if that carer generally is in a priority group nearby, so for example, if a 75-year-old was bringing in a 78-year-old, then they would both be vaccinated even if we haven't quite got to that group. However, we do have to guard against, particularly for the mid-February deadline of the first 4 groups, we need to guard the vaccine supply so that we are doing the highest risk people too. So there is a bit of flexibility in there. It doesn't, however, mean that some carers won't have to come back later if they're younger, if they're in lower priority groups for their vaccine, which I know is not what we would like, but I think it reflects the level of supply that we have in the system to protect the most vulnerable first. Ros, I don't know if I've covered that adequately.
I would just add that Group 6, Priority Group 6, are those that are defined as being a member of at-risk groups, and we might know them much better in terms of those groups that are identified to receive the vaccine, the flu vaccine, if they are under 64, and unpaid carers is a definite group within that. Identification over previous years with regards to unpaid carers has got better with the direct offer of the flu vaccine, so that is helping us. We also have registers of individuals that have registered as a carer, and they are improving all the time. But I will share with you, Paul, that this is one group that does worry me in terms of us being able to reach as much as we possibly can that group when we get to prioritisation Group 6. So we do need to be very clear in our communications and how we are asking individuals to identify themselves, particularly if they are unknown to us. So we are getting better. We have improved over the flu vaccination programmes in recent times, but this is a group that we do not know its full extent. It's not like a registration that we have through GPs in terms of our age categories or those that are extremely clinically vulnerable. Like I answered that question before. There is a slight unknown quantity about that, but we will be making all efforts to try to reach as many of those unpaid carers. They are essential. They are essential to the working of our health and social care services, and we need to make sure that they are able to be protected through this offer of the vaccine, as well as others across that prioritisation framework.
Ros,
thank you.
Deb has also asked, would this include young carers?
No, it won't actually, Delith. The prioritisation framework has been built on the premise of risk. I tried to explain that right at the beginning of my talk, that the JCVI has been really clear with regards to who should receive the vaccine first, and the priority order and sequence of that, and that is based on known understandings and assessments of risk, whether it's by age or whether it's by underlying health condition. And the evidence that was presented to the JCVI and is known to experts, particularly explained very well by Public Health Wales and the head of the vaccine unit there in Public Health Wales, is that the risk to young people from COVID is so much lower that at the moment it's very much being governed by age profile. And even though this was raised specifically with regards to young carers, we are feeling that they are so not at risk, that they're so much lower risk from COVID and poor outcomes from COVID, that it's absolutely essential that if they are caring for somebody vulnerable and older and within those priority groups, that we try to ensure that who they're caring for accesses the vaccine, and that again, that might be certain circumstances in which we are trying to work through our call centre to enable that to happen. And support that can be given in terms of access, but the young carers themselves, they are not considered to be of sufficient risk at this time to be offered the vaccine. Those supplies of the vaccine need to be given to those that are at risk in that order first.
Thank you, Ros, and thank you all for a really comprehensive and incredibly impressive summary of where you're all, we're at the moment in all the areas that we've described. So many thanks. Incredibly impressive. I'd like to ask the board, will they approve the recommendations, please, in both papers 4.2 and 4.21? Many thanks. And I'd also like to give us a 10-minute break before we go on to the performance report. Diolch. you everybody. Diolch and welcome back. We're going to continue with our board meeting. The next item, and before we do that, I'd just like to thank everybody because I thought the discussions, the questions, the presentations gave not only the board assurance, but I'm sure they gave the public assurance, as well as the the softer things of the compassion and the dedication of everybody. So we're now going to go on to the performance report. We've all read the report, which is very comprehensive. So if I may, I'm going to go straight to questions. So for any of the board members who have questions on the performance report, please. Right, I'm going to go to Judith and John, and then Simon.
Thank you. Thank you, Chair. Thank you, Hugh, for the report. My question relates to mental health, which is on page 15 of the document. I suppose, again, obviously concerned about the where we're up to, because the figures are really concerning, and I do know a lot of the detail from my conversations, so I know some of those reasons why. But my question is actually about the comparisons and whether we're confident in that comparative data. The reason I ask that is this is a fairly consistent topic that the vice chairs discuss as a group and also discuss with the minister. And those figures there in terms of comparisons don't bear out the information that I received. So I just wonder, where we get that from. And also, I suppose a question, because, the issue about the patient administration system has been there for some time. I think October last year, maybe earlier when it was first there. So I don't know that is the real sort of key to what is going to make a huge difference. I'm sort of concerned that the actions there may not make a huge amount of difference. Thanks.
Thank you, Judith. In terms of the data, obviously the data is driven by what's being put through into WPAS, and the monitoring is based on that. We are conscious that, and I agree with you in terms of the issue having been there for quite some time now in terms of the implementation of WPAS. Having said that, I think in doing the work, it became quite clear quite quickly that the pathways we were talking about and capturing the pathways was far more complex than had been first envisaged. We've had a number of issues in terms of data quality that have been addressed or are gradually being addressed, and there are further issues in terms of the of trying to capture the complexity of the pathways into the WPAS system. It's been a major undertaking, not least because the previous system supplier hasn't been engaging as well as we would have liked in terms of our move into WPAS. So that's been a challenge. In terms of the comparison with the rest of Wales, might have a further conversation with you about your concerns and the data that you're concerned about specifically. But in terms of what we're dealing with, I'm confident that what's being pulled out of WPAS is being reported correctly. But there may be issues, as I say, in terms of data quality that we still need to address. Andrew, I don't know if you've got any comment on the performance itself.
Thanks.
Sorry, it's taken a while to unmute. There was a bit of a delay there. Apologies. I think, as we know, and as we've acknowledged at the board previously, the performance that we're displaying in this area isn't the level that we find acceptable or want to see continue. There are a number of developments that I think will help. Over the last few weeks, we've appointed three new members of staff that will add around 24 clinical sessions to the service, and a clinical lead psychologist that adds another 10 sessions, and that role will also help us plan and map our way through the waiting list and for a trajectory, and also a trajectory of improvement on that. I think there are some challenges though we're facing in just the delivery of the service that we're trying to crack. Obviously, we've rolled out Attend Anywhere Everywhere, which is the digital platform for remote consultation, but take up amongst this particular client group is not good, and in some cases for the types of assessment and interventional therapy they're trying to deliver, it's not the best platform. I've asked for some additional specific support from the estates and facilities team internally to try and identify some suitable additional clinical space that would enable us to increase our face-to-face capacity quickly. I've also asked for, I know we've been doing a number of waiting list initiative clinics through January, and we have more planned in February, and I have asked for an update just in terms of by the end of January, what will we have done over and above what we were planning to do originally, and then what we've got planned in addition in February. So perhaps, Judith, I can feed that back to you outside of the meeting once I've got that number, because it hasn't come through in time for the meeting this morning. But there are a number of things happening to try and increase capacity and manage some of the complexity that the COVID situation is presenting us in terms of service delivery.
Yeah, I'm happy to have those discussions. I'm really pleased to hear that some exploration of alternative sites has been looked at to enable face-to-face consultations. Thank you.
Thank you, John.
Thank you, Chair. Can I just first note to board members that this particular performance report has been reviewed by the People Planning Performance Subcommittee to this board, and a summary of that is noted within my report. Can I ask, accepting the challenges that we're facing around COVID and noting within the report the compliance that we've got with regards to urgent suspected cancer patients and the commencement of their treatment. In the last month, that has improved by 1%. I understand the challenges. I guess my question is, what are our plans to improve, particularly for individuals within this group who understandably will be very concerned in light of their diagnosis?
Yes, thanks for that question, John, and I think it's an area that is of significant concern to me and the service in terms of the indirect consequence of the COVID pandemic, if you like. And I think certainly the impact, some of this is the impact of the action we have had to take just before Christmas in order to redeploy staff and reduce our theatre capacity to be able to provide the level of critical care support we needed to the emergency workload we were seeing. But in doing so, that then compromised our ability to provide safe green pathways for some of these patients as well. Our expectation is the biggest volumes of backlog at the moment are within neurology. So whilst the numbers are bigger, they're also the numbers of patients we can get through on a list safely is higher. So we anticipate we'll be able to make some significant inroads into that through February. And across the piece, the patients that have been delayed in particular over the last month, we intend to have made that backlog up by sometime around the middle of March, would be our expectation from the plans we've got. We're hoping that with the plan we've got to increase our enhanced care in Prince Philip, and also then the follow-on plan that I mentioned earlier for Withybush as well, that's a similar model, we would be able to further increase our urgent capacity as well. Obviously, through this period, we've also continued to use the Wherndale as an additional site for capacity, and that will continue through the rest of this quarter. We're in discussions about what we do with them around how that looks beyond the 31st of March. I suppose the only caveat on that would be compared to where we were much earlier in the pandemic, maybe through the first couple of quarters of the pandemic, our access to the Wherndale is significantly reduced from where we were. So we've got about 40% of their capacity now, whereas in the first part of the pandemic we had more like 70 to 80%. That 40% now, as a local negotiation, is a higher percentage of the local capacity than other health boards have managed to negotiate with their independent sector providers. So in that sense, I think we've done as much as we can to secure additional capacity that way. But certainly the focus of the service now, as the COVID position eases on each site, is how we really get back into not just re-establishing those services, but making some inroads into the backlog and the treatment times we've got for some of these patients.
Thank you very much, Chair. Thank you, Andrew.
Simon and Anna.
Thanks very much, Chair. The impact of COVID is listed on page 9. I'm looking at the stroke services and is concerning the sort of continued decline in some of the measures. I'm looking at the 26.8% of patients who've actually been admitted to a dedicated ward within 4 hours, and it's a bit disconcerting that 26.8% is actually the best in Wales. So that begs the question, what is the worst? So what the question is, the impact of COVID, is COVID entirely responsible for these declining measures, or are there other factors, that other sort of structural factors within the stroke service that would sort of would cause challenge anyway?
Alison.
Thank you.
Thank you, Chair. Thanks for that question, Simon. I think it's multifactorial. I think on top of the usual sort of bed pressures and emergency department pressures that we see in the winter, COVID has added another layer onto that. So we've seen a number of wards having to close for a number of weeks because of outbreak areas, and some of our stroke units have been impacted by that. But I think the other issue, which is probably a significant issue across Wales, is that the target is actually set against the direct admission to a stroke ward within 4 hours. And by default, any COVID positive patients that are identified as positive, either before they come to ED or when they get to ED, would need to be placed on a red ward. So by default, by not going straight to the stroke ward, they automatically fail the target. So I think it's the usual pressures, but it's been impacted further by bed pressures due to COVID and distancing and needing to reduce the numbers, and then further impacted by outbreaks, but then also impacted by the fact that any positive patients would need to go to a different ward. I mean, I have to say that the units have been very good at putting in alternative pathways, but I think it's probably a combination of those things. I'm certainly not aware of any specific issues within the stroke services here. We have had some multidisciplinary COVID staff sickness, but not that would specifically impact on that particular target.
Do you want to come in?
Yeah, I think Alison actually probably covered it just towards the end. It was just to give some assurance that even with those challenges, I know from an operational perspective, there has been a significant focus on trying to make sure that whenever those pathways have been jeopardised because of the COVID situation, there have been alternatives in place to at least ensure the patient gets the required level of care and intervention in a timely fashion. And I know certainly while I've been on call in January, a number of the challenges we've had in terms of managing our capacity has been about how we rejig or shuffle things around to make sure we maintain those pathways on each site. So it's as Alison says, it's there's something around the definition and the fact it's a direct admission to a stroke ward, but we've done everything we've done everything I think we could during that time with the circumstances that we were facing to maintain the pathways in as best way we possibly could to ensure the level of care was provided, even if we weren't doing it in the stroke ward.
Thank you. Thanks, Alison, and thanks, Andrew. If I could bring in Anna.
Thanks, Chair. My question does kind of build on Simon's, really. If we take the performance report as a whole, we can see that the COVID dividend is punishing absolutely across the board in pretty much every metric, and there's a risk, I guess, that COVID becomes the blanket explanation for every deterioration or every negative change in performance. And I'm wondering, from an assurance perspective, whether that is sufficiently reliable, and what might we do as a board, or indeed what are the executive doing to try to understand what is the COVID effect, and is there any other explanation for some very significant deteriorations in performance? How can we make sure that that we're staying sort of attuned to the possibility that there may well be other things going on in our system that we might have more control over than we've been habitualised to think through this long now experience of being in the midst of a pandemic.
Chair, may I come in, and then Andrew, I'm sure there's operational detail that you can contribute to as well. But just in terms of the report as a whole, I'm very conscious that it is somewhat.
We've lost you. Oh, you break. Could you commence again, Hugh? You broke up.
I do apologise. The connection from Llandysil is a little bit flaky. I am conscious that the report as a whole is sometimes challenging to see the wood for the trees. And to determine what the underlying cause is for certain issues. And we do have a board seminar coming up in February, where we'll have an opportunity to look at a different way of reporting and understanding how that can help us determine what the causes of variation may be and on our performance. I think that would be quite a critical kind of overlay for us, and that will allow us to report in a different way and to allow us to show you what the critical issues are on a changing basis. So that's I guess the strategic overlay for the performance report. We need to do that in a really measured way. We need to do that in a careful way, so that we don't lose some of the wealth of information that we've already got in the performance report. So that's kind of my view on it.
Mandy, did you want to come in?
Yes, please, if I may. Oh, it says that. Still saying I'm unmuting. Can you hear me?
Yeah, hear you. Thank you.
Okay. Yeah, it's really just to provide some assurance that whilst the significant focus and energy has been deployed around focusing on the here and now, the COVID, and how we make sure that we're able to respond, I just want to provide some assurance that some of the routine surveillance work that we do, particularly around infection prevention, control and safeguarding, has continued regardless. And whilst we're dealing with a different type of infection as our predominant activity, we have continued to maintain steady improvements on all other infection management. So that is just one example. And particularly looking in the world of safeguarding, whilst again the team have been incredibly busy dealing with safeguarding matters that we would hope wouldn't be in such volume and such number. Unfortunately, because of COVID, we are seeing an increase in certain aspects of safeguarding, but nevertheless, we've continued on with that. Likewise, if we were looking at violence and aggression and other key pieces of work that we do on a day-to-day basis, all of those are monitored, surveilled, and if necessary, a deep dive is undertaken into specific areas where we feel that there needs some further scrutiny. So it's just to provide some assurance from a couple of examples.
Thank you, Mandy. If I could bring in Andrew as well.
Yeah, no, it was just to add. I mean, I think with regards to COVID, and I think Anna makes a really good point. It's easy to default to say COVID is the problem, is the default issue with everything and the only issue. And whilst we can't escape the impact that COVID has had on the way we've had to manage our capacity in terms of the complexity of the different pathways we've had to maintain, and the impact it's had on our staff to be able to provide capacity to deliver services, that there is more. In some cases, there's definitely more to some of the performance than simply COVID, and we are, just to give some assurance that we're still that although COVID's happening and we're in the midst of that, we are still continuing some of that improvement work in the background. So, for example, later on today, I will be chairing the unscheduled care steering group we run locally, which is looking at a range of improvement work that we're doing across the unscheduled care system through health and social care, looking at how we develop same-day emergency care, which we've got a couple of pilots running at the moment, how we develop our frailty models, how we develop urgent primary care, contact first. There's a whole range of improvement activity in various different fields like that is still ongoing in the background, because we know that when we come out of COVID, we will still have those issues to address. And whilst those issues also support our response at the current time, they will also be a fundamental part of our service model and system going forward if we're to get to the levels of performance that we would, as a health board, would want to see during, if there is such a thing as normal time again, then during normal time again, that would be the level we'd want to be getting to. So it's not, I don't want the board to feel that we're not looking at any of those issues or progressing any of that work. It's just there are some very real issues in terms of staffing, capacity, even just definitional issues. So, for example, some of our A&E performance is determined by the fact we've got different areas providing different pathways that wouldn't count within the definition to tick off a patient being dealt with within 4 hours, for example. So there's things like that that are having an impact that would naturally correct themselves, but there is improvement work going on in the background too.
Andrew. Steve, would you like to come in?
It was probably just more of a general point. I mean, obviously there are a number of issues in here, and I would echo Andrew's point around COVID and the underlying sort of pathway issues that will, I think, stand us in much stronger stead going forward. I guess I just wanted to say, really, this is for the public who are watching at the moment, that the numbers who are waiting for our care across all areas is heartbreaking at the moment. We heard from Mandy earlier about the work we're doing to try and keep in contact with those many thousands of people, but I guess I just wanted to reassure, on top of all of the specific work, that we are very conscious of that we do want to recover back to what was a relatively positive and an improving position for the health board, and we're going to be on that as soon as we possibly can as we come out of the other side of this.
Thanks, Steve. Based on this discussion, and I'm picking up what you've just said, Steve, and also Hugh's point and Andrew's and John's and Anna's, we have focused in the last hour discussing our response to COVID, which is extraordinary. But there are also many people out there who are in fear and suffering from other illnesses, which they wish assurance and knowledge and sight of hope as to when they will be treated. And John raised the fact that this report, the performance report, is considered at detail in his committee, PPAC. And I'd like us to discuss at the board seminar what we should be considering in the performance report that's important for the public and important at public board. And I'd like us to have a consensus about that. And so I obviously would expect cancer to be one of those areas, perhaps stroke, perhaps A&E. I don't know. That's for discussion. But if we can see what, similar to the presentation of the business case, if we can see those areas that we choose to focus on at board level and our trajectory as to when we are going to improve and even how, then I think that would provide assurance to the board and to the public who are looking in at this report. The report's excellent, but it's so full of detail. It makes it difficult to understand where the light is, where we're going, when are we going to improve in some of the key services which cause the most concern. So I would really welcome that discussion at our board seminar on the 11th of February. And again, it's also about the metrics that we choose to measure. Andrew mentioned it's different pathways and different A&Es, and therefore perhaps the 4-hour measurement isn't the appropriate. So let's look at the appropriate measurements to give the board and the public assurance that we are recovering those services, and the work is going on in the background to continue that recovery and when we expect to be recovered by. So I hope the board is happy with that proposal. Thanks, John. I can see Phil, you'd like to come in.
Yes, thank you, Chair, and I would fully support that. I just wanted to add to the comment that the Chief Exec made about us acknowledging just how difficult this is for our public, waiting for tests much longer than they would have ordinarily expected to do so, but also the impact this has on our staff, because the worry of the public is also mirrored by the worry of staff who want to treat their patients but but are unable to do so in the normal way they would, and that will be reflected in our clinicians, therapists, nurses and doctors, but also in those managing waiting lists and our administrative secretarial staff. So all across our staff there will be that concern. Of course, our staff are members of the public, and I think have to remember as we hopefully emerge from the pandemic, with the vaccination and completeness, as we talked about earlier, that just thinking of the well-being of our staff through all of this, I think that's going to be a real key factor, because I do think it is worrying them.
Well, I totally agree, and that's why I believe we have to have that consensus with our staff of which areas we focus on in that recovery, and I think that will, as well as reassuring the public, it will also assist with that staff worries and concern and well-being. So we can discuss again, and I'm sure you're already doing this, but how we bring that voice firmly into that decision making about, you know, which of those key areas. Okay, yeah. Well, thank you, everybody. I'm going to draw that to a conclusion. Is everybody happy to accept the recommendation on that report? And many thanks to everybody. We're now going to go on to John, the report of the People Planning and Performance Assurance Committee.
Thank you, Chair. So the report notes the details of the meeting held on the 17th of December. As noted within my report, there are no matters that I would seek any board consideration or approval, and no matters of risk or issues that I would raise or bring to the board's attention. So the summary is as it stands, and I'm happy to take any questions.
John. Any questions for John? Very much, and that's a reflection of the comprehensive nature of the report rather than any other issue. We go on now to the report of the Quality and Safety and Experience Committee. We have two reports there. I can hand over to Anna.
Thank you, Chair. Yes, two reports to reflect our two meetings since we last met as a public board. The reports are as they stand. I think they give a sense of the complexity of the issues that are being managed by our staff and faced by our public, and of course many of those issues we've discussed through separate agenda items today, so I won't go through the detail. I think there's just one aspect that I'd like to draw attention to, and that's around the CUSIAC focus we've had recently around services for children and young people, and particularly around specialist CAMS services, and I think to reiterate there is this sort of CUSIAC expectation for a continuing strategic focus on the needs of children and young people, recognising that while our operational teams are working extremely hard to maintain and improve services, there is likely a strategic gap which will mean that as a board we need to continue to focus and pay attention to this area of our work and to the children and young people who are affected by our provision. So it's a watch this space, I think, and CUSIAC is certainly following that agenda really closely. Happy to take any questions.
Thanks, Anna. That's really reassuring. Any questions for Anna? And thank you and your committee to scrutinising that. Michael?
Thanks, Chair. There are two reports in the board papers, one reflecting the Finance Committee's meeting in November and one reflecting the meeting in December. In most respects, the contents are slightly out of date because the Finance Committee also met this week to discuss the month 9 position, and Hugh's on the agenda in a short while to take us through what the current position is for the Health Board, but happy to take any questions on the content of the two reports.
Any questions, colleagues? Okay, many thanks. We now go, there's one thing to be approved as well. I understand it's the procurement of the haematology and coagulation managed service agreement.
Well, I think that's next on the agenda, Chair.
Sorry, any questions to Michael? Okay, we go to the next item. Many thanks, Michael.
Chair, many thanks. The I think the paper on the procurement of haematology and coagulation managed service agreement, it largely speaks for itself. Just to give the board assurance, this has been through the Finance Committee. Finance Committee scrutinised it and agreed to recommend this to the board for approval. The path from here on will be on to Welsh Government for Welsh Government's approval before we go out to the market for tendering. Just to give further assurance, the values we're talking about here are within the current budget of the pathology team, and it does give us an opportunity to transform some of the services provided by that team. So I think it provides us with a much more robust setting for that team to function.
Thank you, Hugh. The board's happy to approve that. Thank you very much. Any other questions for Hugh? Okay, thank you. We'll go on. Yes, sorry, Judith, please come in.
Sorry, I was just signalling agreement to the business case.
Thank you. Thank you. I'll go on then to item 5.1, which is the committee update reports. Hang on, Chair, we've missed the finance. I missed the finance report. Sorry, 4.7. Hugh.
Yes, my furrowed brow indicated confusion. Thank you, Chair. I won't take much time to go through this because I am conscious of time. We've got a fairly stable financial position as we sit here now. The risk is probably as much that we underspend as we overspend against our forecast position. I say that is a risk because it is a risk that we don't deliver against what we have forecast as a board, and it's really important that we set out clear plans, set out clear forecasts and deliver against those. So it's a favourable risk against that position, but nonetheless a risk that we could deliver a position that's better than that. One issue to call out at this stage is the significant step change we've seen in staff costs on page 7 of the report, and largely as planned. There's from month 7, there's been an increase, quite significant increase in our staff costs, which demonstrates a phenomenal achievement, as I know we've already talked about, of the recruitment team in particular in responding to the requirements of COVID. We've also been successful in recruiting additional locum staff, medical staff in particular, which has driven up the costs for us, largely, as I say, as planned and within the budget envelope. Just very conscious that there are some issues coming from this year going into next year. I don't want to talk particularly about next year in this session. I know we'll have more opportunity later, but there are some issues in terms of this year's cost pressures going into next year, particularly around field hospitals that we need to be cognizant of, TTP, vaccinations and cleaning standards. And those are commitments that are now being made, which will give us a commitment, a pre-commitment, if you like, into next year. We'll go through that in more detail in the forthcoming Finance Committee for February. That's it, Chair. I'm happy to take questions.
You and apologies. Questions for Hugh? Okay, well, I know that the Finance Committee meets monthly, and there's excellent scrutiny each month, so thanks, Hugh. Now go on to the committee update reports. We've got a number of updates there. I think the main thing for us to consider is the Charitable Funds Committee approving the terms of reference. The board happy to approve the terms of reference? Yep, thank you very much. I don't know if anybody would like to add anything to the committee update reports.
No, just to add, Chair, there was no matters to raise the board's attention from the committee board or from Charitable Funds or the Health Professionals Forum, apart from the terms of reference which you've just approved.
Super, thank you. Is everybody happy to accept the recommendation? Thank you. The next is the joint committees and collaboration.
I'm happy to take any questions, Jim.
Any questions on that paper? Okay, thank you. The statutory partnerships update, any questions? Okay, thank you. And the board annual work plan?
We like the items, Chair, that we've already discussed today on the programme business. Okay.
Thank you. Well, thank you, members. That's the end of the public session of our board. And so we'll reconvene straight away to our private session. Diolch.